Hello everyone, good evening everyone. So welcome to this, thank you Prudvila, thank you for the compliment. So welcome to this INICET High-Yield Revision session. So basically, we all know the exam is just in 2 weeks, in fact less than 2 weeks time to be very honest. So the focus of this session of this next one and a half hour, 2 hours, maybe 2.5 hours, basically 1.5 to 2 hour session is going to be that I revise the most important topics in a brief and concise manner. Now, as far as pediatrics is concerned, and especially the last 7-day revision part of revising your entire syllabus is concerned, as far as pediatrics is concerned, I always emphasize this whenever I'm starting pediatrics, that pediatrics is a mixture of core pediatrics, which is your general pediatrics and neonatology, and along with systemic pediatrics. Systemic pediatrics as a topic I feel is not something which is worth revising, especially in the last 7 days, if you have done your path, pharma and medicine properly. If you've done your path, pharma and medicine properly, most of the things in the systemic pediatrics would be covered. So don't waste time that, okay, I have to revise systemic pediatrics again as well. Focus instead on core pediatrics topic that will give, you 5 to 7 questions in the exam. On a good day, sometimes they just give 2 or 3 questions. That's obviously variable depending upon from exam to exam. But focus on core pediatrics, focus on general pediatrics, focus on neonatology when you're revising in the last 10 days. And systemic pediatrics, I would instead I would say that your hold over your pathology, pharmacology and medicine should be more, so that actually covers up your systemic pediatrics and you don't waste time revising systemic pediatrics. Alright, so this is a general word of advice from my side for the planning the last 7 or 10 day revision is concerned. And now let's begin with our session of this high yield INICET revision. Alright, so alright, now let's first come to the question number 1. What is the rate of increase? I'll first discuss some questions. We'll discuss these answers and then we'll discuss that particular topics. Okay, what is the rate of head circumference increase in the first 3 months of life? As everyone is rightly pointing out, it's actually B. It's actually B, 2 centimeter per month. Then comes at what age does the height become double of birth height? Now the answer to this question is option C, 4 years. And a child reaches half the adult height at? The answer to this question is option A, 2 years. And last question, which of the following is normal in an infant born with a weight of 2.8 kg, a weight gain of 300 gram in first 2 months, a length gain of 25 centimeter in the first year, anterior fontanelle closure by 6 months, or height at 50th weight at 50th centile, height at 10th centile? The answer to this question is going to be option 2 or option B. Alright, now let's discuss this particular topic. That means that let's discuss normal growth in the first place. Let's discuss normal growth in first place, because a lot of questions from the simple numerical values keep on being asked again and again and again. Be it your INICET or be it your NEET PG, irrespective of whichever exam you are actually focusing upon, multiple questions simply keep on coming from, okay, what is the weight at this particular time point? What is the height at this particular time point? And it is going to be very, very helpful. And especially since these are numbers, it's very important to revise them because we'll keep on forgetting them, right? Let's begin. So we all know that at birth, the normal birth weight is approximately 3 kgs. It's approximately 3 kgs. Let's consider this as X. Let's consider this as X. A baby said to be low birth weight. A baby said to be low birth weight if the birth weight is less than 2.5 kg. If the birth weight is less than 2.5 kg, a baby said to be very low birth weight if the birth weight is less than 1.5 kg. Alright. Now, so the normal birth weight is 3 kg. By the time the child reaches 5 months of age, the birth weight has actually doubled. The birth weight has actually doubled. It has become 2x. By the time the child reaches 1 year of age, the birth weight has actually tripled. The birth weight has actually tripled. It becomes 3x. By the time child reaches 2 years of age, it becomes 4x. It becomes 4x. By the time that child reaches 3 years of age, it becomes 5x. That is 5 times the birth weight. 5x. By the time child reaches 5 years of age, it becomes 6 times the birth weight. It becomes 6x. And by the time the child reaches 7 years of age, it becomes 7 times the birth weight. That is 7x. So if I assume the birth weight is 3 kg, a child will be 6 kg at 5 months of age, 9 kg, that is 3 times the birth weight at 1 year of age, 12 kg at 2 years of age, 15 kg at 3 years of age, 18 kg at 5 years of age, and 21 kg at 7 years of age. So X at birth, double at 5 months, triple at 1 year, 4 times at 2 years, 5 times at 3 years, 6 times at 5 years, and 7 times at 7 years. If this is a sequence that you should remember, you should definitely Remember. Alright, so this is the normal progression as far as weight is concerned. Now let's move towards height. Now as far as height is concerned, when a baby is born, the length of the baby is approximately 50 centimeter. It is 50 centimeter. So the birth length is actually 50 centimeter. In the first year of life, that is from birth to first year, in the first year of life, a baby is going to gain 25 centimeter. A baby is going to gain how much? He is going to gain 25 centimeter, and he'll become what? He'll become 75 centimeter by the time child reaches 1 year of age. Alright. The next year, that is from 1 to 2 year, baby is going to gain exactly half of this. Alright. So by the time the baby reaches 2 years of age, baby will gain what? Half of the first year. That is 25 ka half. So baby is going to gain approximately 12 to 13 centimeter in the next year. So by the time the child reaches 2 years of age, the length of the baby is going to be 87 to 88 centimeter. It's going to be 87 to 88 centimeter. Alright. Further beyond this, the baby is going to gain height at approximately, again, half of 12 to 13. So basically around 6 to 7 centimeter. Baby is going to gain height at 6 to 7 centimeter per year. Such that by the time child reaches 4 years of age, the height or the length of the baby is 100 centimeter. It is what? 100 centimeter. So can you see when baby is born, the height is what? It is 50 centimeter. It is what? 50 centimeter. And baby reaches 100 centimeter. That is twice the birth length by 4 years of age. Contrast this with weight. As far as weight is concerned, weight actually doubles just in 5 months. While length doubling time actually is, it is actually 4 years. It's what? 4 years. Now this actually has implications as far as malnutrition, over and undernutrition both is concerned also. Whenever acute malnutrition is going to be talked about, remember, whenever acute malnutrition is going to be talked about, we will always use a weight-based parameter. You know, let's say I fast for 1 week or I fast for 10 days, what will happen? My weight is going to fall very fast. We gain weight rapidly and we lose weight equally rapidly. That's why weight is always a good parameter for acute malnutrition. While something which takes its own sweet time to grow or not grow, for that matter of fact, is always going to be height. And this is reflected here so beautifully, right? That you're doubling your weight, you're doubling the birth weight in just 5 months, while you're doubling your birth height in 4 years. You're doubling your birth height in 4 years. So 50 centimeter, 75 centimeter, 87 centimeter, and finally 100 centimeter at 4 years of age. 100 centimeter at 4 years of age. After this, the child will keep on growing at 6 centimeter per year till puberty. Till the child reaches puberty. And then what happens at puberty? At puberty, what happens? You have the secretions of your gonadotropins, you have the secretion of your testosterone, which stimulate a growth spurt. Now, the growth velocity during the growth spurt in puberty, the peak growth velocity in females is 8 to 9 centimeter per year. And females experience this during SMR stage 3. They experience it during the SMR stage 3, while males have a peak height velocity during their puberty of 9 to 11 centimeter per year in SMR stage 4. You don't need to, you don't need to rote memorize this. Just go back to your own, 5th, 6th, 7th, 8th or 9th standard. What used to happen? Girls used to grow early. You all remember, the boys used to stay small and girls used to suddenly gain height. They used to start growing. They had their puberty earlier. They have their growth spurt earlier. They had their growth spurt earlier when they had their growth spurt in SMR stage 3 itself. So in the 5th, 6th, 7th standard, the girls were growing. Alright, but they grew what? At 8 to 9 centimeter. And they grew in their SMR stage 3, but when finally SMR stage 4 came, that is your 8th and 9th standard came, that's when boys started to grow. And they grew more. They grew at 9, 10, 11 centimeter, finally resulting in what? The boys having a higher height as compared to girl. So you don't need to rote memorize this. Girls have a smaller peak height velocity, which is reflected in the fact that boys are taller than girls. Their peak height velocity during the growth spurt in puberty is what? It is 8 to 9 centimeter, which is achieved when? During SMR stage 3, earlier as compared to boys. While boys achieve it when? They achieve it during their SMR stage 4, and they have a higher growth velocity during their puberty, which is 9 to 11 centimeter per year. And we can just recollect our own puberty and our own 5th, 6th, 7th standard days to collaborate with this particular fact. Now, moving on towards puberty, what is the first sign of puberty in females? A very commonly, frequently, simple tested fact. It is actually your thylarch. Thelarch basically stands for breast enlargement or appearance of breast bud. Alright, breast enlargement and appearance of breast bud. This thelarch in females is followed by pubarch. It is followed by pubarch, and this pubarch is then finally followed by menarche. It's finally followed by menarche. Just prior to menarche, the girls will have their growth spurt. Alright, just prior to menarche, the girls will have their growth spurt. Now, as far as sequence of puberty in males is concerned, the first letters are exactly the same. So males, obviously males are not going to have thelarch. Male will have what? They will have enlargement of their testes. So first sign of puberty in male is testes enlargement. It is what? Testicular enlargement. This is followed by the same letter I said. So T, after T comes P. So males have what? They will have their pubarch and penis enlargement. They will have what? They will have pubarch and penile enlargement, followed by their growth spurt, and finally the development of axillary and facial hair. Alright, finally the development of axillary and facial hair. So the first two letters are same: thelarch, pubarch, menarche. Males will have from T, they obviously won't have thelarch, they will have testicular enlargement, followed by pubarch and penile enlargement, finally followed by their axillary and voice changes, axillary and facial hair. Just prior to that, they will also have their growth spurt. Again, we just need to go back to our own puberty. What used to happen? We used to suddenly grow tall, all the boys in the house. We used to suddenly grow tall in 8th, 9th standard, but our voice hadn't broken at that point of time, right? We used to become very, very tall, but our voice and our facial hair still hadn't come. And then later, after the growth spurt had occurred, then you finally used to have your axillary and facial hair, which is being reflected by this in the first there is going to be testicular enlargement, followed by pubarch and penile enlargement, then growth spurt, and just after growth spurt you will finally have the development of your facial and axillary hair and the voice changes. Alright, so this is as far as the sequence of puberty in males is concerned. Females is simple: TPM, thelarch, pubarch and menarche. Alright, so this is as far as the length is concerned, how the length actually normally grows. Now moving on towards head circumference. Now at birth, the head circumference of a baby is approximately 34 centimeter. It's approximately 34 centimeter. Now during the first 3 months, a baby will grow head circumference at approximately 2 centimeter per month. At what? 2 centimeter per month. At what? 2 centimeter per month. So 3 months at 2 centimeter per month, how much would have the baby grown? 2 into 3 is equal to 6 centimeter. Alright. Now from the 3rd to 6th month, that is the 4th, the 5th and the 6th month, the baby is going to grow his head circumference at 1 centimeter per month. So in the next 3 months, the head circumference is going to grow at 1 into 3 months is equal to 3 centimeter. The absolute increase is going to be of 3 centimeter. And in the next 6 months of the first year of life, the baby is going to grow head circumference at 0.5 centimeter per month. It's going to grow head circumference at 0.5 centimeter per month. So the total absolute head circumference increase is going to be 0.5 into 6, again 3 centimeter. So in the first year of life, from 0 to 12 months, the baby is going to gain 6 plus 3 plus 3, that is 12 centimeter of head circumference. So from birth, this head circumference is going to become 46 centimeter. It's going to become what? It's going to become 46 centimeter by the time child reaches 1 year of age. And then it's going to become 48 centimeter. It's going to become 48 centimeter by the time child reaches 2 years of age. Alright. Now, when the child has reached 2 years of age, it is 48 centimeter. My question to you guys is, tell me the answer in the comment section. What is the adult head circumference? What is going to be yours and mine head circumference? Tell me what is the adult head circumference. Tell me in the comment section for those who are watching. So stay small. For those who are watching, please tell me what is the adult head circumference. Can anyone tell me what is the adult head circumference? Can anyone tell me what's the adult head circumference? So Kona and Sonov, you are wrong. You're actually wrong. PSK is right. The adult head circumference is approximately 53 centimeter. It is actually approximately 53 centimeter. It is approximately 52, 53 centimeter. That's the better answer as compared to 50 centimeter. Now 48 centimeter. Now 48 centimeter is 90%. It is 90% of 53 centimeter. It is 90% of 53 centimeter. So can we say that you have already achieved 90% of your head circumference growth or 90% of your brain growth? Because head circumference is growing because of the brain, right? You have achieved 90% of brain growth. 90% of brain growth has already occurred by the time you have reached 2 years of age. By the time you have reached 2 years of age. So can we say that, right? We can say this, that 90% of brain growth or 90% of the head circumference growth has already occurred by the time child has reached 2 years of age. All right. Now, this brings me to the growth curves. This brings me to the important growth curves of various tissues. All right. I'll start with the easiest growth curve, the one we just discussed right now. So this growth curve is going to be a what? As we can clearly see, you have already achieved 90% of your growth by what? 2 years of age, and then there is a plateau. This growth curve is of which tissue? This is going to be of brain. This is going to be of your brain or CNS. Understood? Then we come to some other tissue. Let me ask you, what is going to be this tissue? This is a tissue which has stayed silent. This is a tissue which has stayed silent in 10-12 years and then suddenly shooting up. Tell me what is going to be this tissue. Can anyone tell me what is going to be this tissue? Can anyone tell me what is going to be this tissue? The one which has stayed silent in 10-12 years and then when finally puberty is hitting, it is growing rapidly. Okay, exactly. Megha is absolutely correct. This is the gonadal tissue. This is going to be your gonadal tissue. All right. Now, next we come to this tissue. If we look at this tissue very carefully, this is not a very perfect graph, frankly, but this has grown very rapidly during the initial first phase. Then there is a plateau. And then again, when approximately 10-12 years of age has happened, again the growth has started to occur. So initially there is going to be very rapid growth. Then there is going to be a plateau, and then there is going to be another phase of rapid growth during puberty, during growth spurt. So this basically denotes your somatic tissue. All right. And lastly, this is the last tissue that I want to talk about, which has its peak growth between 4 to 8 years. This is your lymphoid tissue. This is which tissue? This is your lymphoidal tissue. Alright, so these growth curves are very important. These curves are also sometimes called as Scammonson's curves or Scammons curves. Alright, these are sometimes called as Scammonson's curves as well. They can ask you. So now let's go back to our original questions. What is the rate of head circumference increase in the first 3 months of life? So we just discussed this. First 3 months of life is 2 centimeter per month. Then next 3 months is 1 centimeter per month, and the next 6 months is 0.5 centimeter per month. So as we already discussed, the correct answer to this question is going to be option B, 2 centimeter per month. At what age does height become double of birth height? So we already discussed that at birth the height is what? It's 50 centimeter. And it reaches 100 centimeter. By 4 years of age. So correct answer to this question is going to be 4 years. Next question is a little better question. A child reaches half the adult height at. So adult height, if we take adult reference male or female, it's going to be approximately 170 centimeter. Right? Adult is going to be approximately 170, 175 centimeter. So half of adult height is what? It is 85 centimeter. It is 85 centimeter. So if you look at this particular thing that I talked about, 85 centimeter was coming when? 85 centimeter was coming approximately at 2 years of age. At 2 years, you were approximately what? You were 87 to 88 centimeter. So 85 centimeter will come just prior. It will come just prior to 2 years. So best answer to this question, a child reaches half the adult height by, the answer is going to be what? It's going to be 2 years. It's going to be 2 years. If they want a more specific answer, it's going to be just prior to 2 years. A better answer probably would be 18 to 24 months. A better answer probably is going to be 18 to 24 months. Alright. So this is as far as This question is concerned. Next is, which of the following is normal in infant born with a weight of 2.8 kg? Alright. Now, a weight gain of 300 gram in first 2 months. This is so low. A 2.8 kg infant will become what? A 2.8 kg infant will become 5.6 kg in 5 months. So even if I take per month gain, it's approximately going to be approximately 600 gram. So in the first 2 months, the baby is going to gain how much? 600 grams. 600 into 600, that is approximately the baby is going to gain 1 kg, not 300 grams. So option A or option 1 is going to be incorrect. This is going to be incorrect. But look at the second option, length gain of 25 centimeter in first year. This is going to be absolutely true. Like I said, at birth, the length is 50 centimeter and it becomes 75 centimeter by the time you reach 1 year of age. So option B is going to be the correct answer to the question. Option B is going to be the correct answer to this. Option B is going to be the correct answer to this particular question. Alright. Now, let's move on towards these two questions. Now tell me what is the answer to this particular question. First, you guys have to tell me what this particular instrument is. You have to tell me what this particular instrument is. What is this particular instrument, and tell me the answer to this particular question. Excellent. So everyone knows this. This is an easy question. Obviously, this is a Shakir's tape. This is a Shakir's tape, which is used to measure what? Which is used to measure mid upper arm circumference. It is used to measure mid upper arm circumference. It's used to measure mid upper arm circumference. And we all know mid upper arm circumference. As far as mid upper arm circumference is concerned, more than 12.5 centimeter is considered normal. 11.5 to 12.5 is considered borderline. It's considered borderline. While less than 11.5 centimeter is considered to be severe acute malnutrition. So let's look at this. This is how it's there in the Shakir's tape. Less than 11.5 centimeter is red. Less than 11.5 is red. 11.5 to 12.5. 11.5 to 12.5 is what? It's yellow. And more than 12.5 is actually, if you look at this, more than 12.5 is coded green. Alright, and next is this. This is what? This is a Harpenden caliper. This is what? This is a Harpenden caliper. And this is used to measure what? This is used to measure skin fold thickness. It's used to measure skin fold thickness. And the site where it is used to measure skin fold thickness includes your triceps, your biceps, and your scapula. Your triceps, biceps, and your scapula, out of which the most common site is triceps. Triceps is the most common site. It is the most common site. Always remember that more than 10 mm is considered as normal, while less than 6 mm is considered to be malnourished. Less than 6 mm is considered to be malnourished. Alright, with these two questions in mind, let's discuss how do we actually assess growth. Now, as far as assessment of growth is concerned, it can be done with the help of age independent parameter, or it can be done with the help of age dependent parameter. Now, as far as age dependent parameters are concerned, they are very obvious. This basically includes your weight for age and length for age. Basically, if a child is 2 years of age, then the weight should be between this to this. If the child is 2 years of age, the length should be between this to this. Basically, you'll get a band. Basically get a band of values that, okay, if a child is 2 years of age, the weight should be 12 kg. If not 12 kg, the child should be between 10 to 14 kg or 11 to 13 kg, like that. Similarly, as far as length for age is concerned, if a child is 2 years of age, the length of the child should be what? It should be 87 centimeter. If not 87 centimeter, if I'm going to consider between -2 to +2 standard deviation, it's going to be between 85 to 88 centimeter or 85 to 90 centimeter, like that. So basically, age dependent parameters they basically have a band. As far as age independent parameters are concerned, this basically includes your mid upper arm circumference. This includes your skin fold thickness. And this includes your weight for length. It includes your weight for length. It includes your weight for length. Now, as far as these age independent parameters are concerned, they will basically have a cutoff, you know. As far as mid-upper arm circumference is concerned, if the mid-upper arm circumference is above 11.5 centimeter, it's normal. If it is below 11.5 centimeter, we'll call the child as having SAM. Same for skin fold thickness. If it is above 10, irrespective of the age of the child, irrespective of the age of the child, irrespective of the age of the child, we are not relying whether the child is 1 year old, 2 year old, 3 year old, 4 year old. Irrespective of the age of the child, there is a particular cutoff. There is a particular cutoff. If the child is above that particular cutoff, we'll say the child is normal. Child is normally nourished. If the child is below that particular cutoff, we'll say the child is malnourished. So age is taken totally out of equation as far as your age independent parameters are concerned. Alright, that's the entire point of having an age independent parameter, that even if you don't know the exact age of the child, even if you don't know the exact age of the child, you can still judge whether the child is nourished or not. You don't need to know the child is exactly 2 years age, 3 years age to know, okay, the weight should be this much or that much. Even if you just take that particular parameter and you know that the parameter is above that particular cutoff, you can say the child is nourished. Or if the child is below that particular cutoff, you can say the child is malnourished. Same goes for weight for length. If you look closely at weight for length, do we need age in it? Is age coming in weight for length? No. You just take the length of the child. For that particular length, this should be the weight of the child. That's it. No requirement of age. That's why weight for length is also a age independent parameter. It's also a age independent parameter. Just look at the length of the child, take the weight of the child. For that particular length, which can be anything, what should be the weight of the child? It should be between this much and this much. You don't need to know the age of the child. You don't need to know the age of the child. So that's the entire point of age independent parameter. Even if you don't know the exact age of the child, you can still calculate whether the child is nourished or not, whether the child is malnourished or not. Alright, especially common in lower socioeconomic status where the mothers don't remember the exact birth date of the child. Very common, you ask them when is the birth of the child, they will say, oh, Diwali ke paas aaya tha, oh, Eid ke paas aaya tha, stuff like that. They won't remember the exact date of the child, date of birth of the child. Alright, so in those particular scenarios, these age independent parameters become extremely important. Another small point as far as mid-upper arm circumference is concerned, that remember this mid-upper arm circumference is used from 6 months to 5 years only. It's used from 6 months to 5 years only. In this particular 6 months to 5 year age bracket, it is age independent. For all children between 6 months to 5 years, the mid-upper arm circumference should be above 11.5. If it is below 11.5, you will say the child is having what? Child is having severe acute malnutrition. Child is having severe acute malnutrition. Now, tell me the answer to this particular question. 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 First, tell me what is this child suffering from and what is the answer to this question. Alright, everyone is answering it correctly. The answer to this question is going to be poor appetite. It's going to be poor appetite. Alright, so this is a child who's suffering. As we can clearly see, this child is having what? Child is having edema. Child is having, even if you look at the feet carefully, you can clearly see the child is having edema. Now, if the child is having edema, we basically know this child is suffering from what? This child is suffering from kwashiorkor. This child is suffering from kwashiorkor. And in kwashiorkor, there is poor appetite. In kwashiorkor, there is poor appetite. Marasmus has good prognosis. Marasmus has good prognosis. Marasmus has calorie deficiency. And marasmus has simian facies. Marasmus has simian facies. Alright, so the only thing which is related to kwashiorkor in this particular case is poor appetite. The only thing which is related to kwashiorkor in this particular case is poor appetite. Now, a very important concept for everyone who's here, for all the 80 people who are here and watching this, a very important concept and the difference between kwashiorkor and marasmus that I'm going to tell you, which is radically different from whatever you might have learned. Please unlearn it. Please unlearn whatever you have learned, that marasmus is calorie deficiency and, kwashiorkor is protein deficiency. That is an absolute rubbish concept. Let me be very, very clear about it. That's an absolute rubbish concept. Both kwashiorkor and marasmus are protein energy malnutrition. Both kwashiorkor and marasmus, both are what? Both are severe forms of protein energy malnutrition. Both are severe forms of protein and energy malnutrition. So there is protein deficiency, there is loss of protein in both. It is not that in kwashiorkor there is loss of protein and in marasmus there is not loss of protein, there is only calorie deficiency. No, that's a rubbish concept. That was an old concept. Let's actually learn the difference between kwashiorkor and marasmus today for the first time. Alright, let me tell you what is the actual difference. See, there is loss of protein. There is loss of protein in both kwashiorkor and marasmus. It's not that protein is not lost in marasmus. The only difference is from where that protein is lost. In case of kwashiorkor, the body undergoes a maladaptive process and body starts to lose the visceral protein. What is this visceral protein? Visceral protein includes your albumin. Visceral protein includes your enzymes. Visceral protein includes your neurotransmitters. This is the example of visceral protein. In case of kwashiorkor, because of the protein energy malnutrition, the body loses visceral protein compartment. In case of marasmus, when the body has to lose protein, where does the body lose protein from? The body loses protein from the muscles. That is your somatic protein. Now understand and realize this, that the visceral protein, the neurotransmitters, the albumin, the enzymes, they are way more important for you to survive as compared to your somatic protein. Yes, somatic proteins give shape to the body, but for you to essentially survive, for your brain to actually function, you need those neurotransmitters, you need those enzymes. In case of kwashiorkor, the body has lost the visceral protein compartment, has lost those albumin, has lost that enzymes, has lost those neurotransmitters. No neurotransmitters, that's why the child is so lethargic. That's why the child doesn't have any appetite. That's why the child has poorer prognosis and that's why the child ends up dying more. Contrast this with marasmus. The adaptation is better. The body has lost protein, but body has preserved the important visceral protein, but the body has lost the somatic protein. That's why the marasmus child is irritable, but still has the appetite. That's why the marasmus child, because, why is he irritable? Because the neurotransmitters are still there. He wants to eat. That's why the appetite is good. That's why they have a better prognosis. So stop thinking of kwashiorkor as protein deficiency and stop thinking of marasmus as calorie deficiency. That's an outdated concept. The actual difference is from where the body, both are protein energy malnutrition, but from where the body actually ends up losing protein. Kwashiorkor, you end up losing it from the visceral compartment. In marasmus, you end up losing it from the somatic compartment. Visceral compartment is much more important for your body than somatic compartment. That's why kwashiorkor is maladaptation. That's why kwashiorkor, poor appetite and a much poorer and bad prognosis. Alright. So let's write that down. In kwashiorkor, there is loss of visceral protein compartment. And this leads to loss of your albumin. This leads to loss of your neurotransmitters and your enzymes. And this in turn leads to your edema, poor appetite, apathy, lethargy, and overall a poorer prognosis. While in case of marasmus, there is loss of only somatic protein. Now, when you lose somatic protein, you will lose somatic protein from here. So the face of these children, of these marasmus children, becomes like that of a monkey. It becomes like that of monkey, which is called as simian facies. Alright, so this is the main difference. As far as kwashiorkor and marasmus is concerned. That's an outdated concept that there is protein deficiency in kwashiorkor and there is calorie deficiency in marasmus. I will make you guys write that down because examiners can be also outdated. We all know examiners can be outdated, but do remember that the actual difference is from where the body is losing protein. That is the main point. Okay. Yes, if in exam they ask you calorie deficiency occurs, then the answer is going to be marasmus. If they ask you in exam protein deficiency occurs, then the answer is going to be kwashiorkor. Sure, but do understand the basic concept that there is protein loss in both the cases. The only difference is from where it is lost. Since it is lost from the visceral compartment, kwashiorkor is a maladaptive process. It's a maladaptive process. While since it's lost from the less important protein compartment, marasmus is considered an adaptive process. All right. So this is the important differences. What is going to be the prognosis in Kwashiorkor? Like I said, no neurotransmitters, no appetite. So poor prognosis, poor appetite, no neurotransmitters. The child is going to be very, very lethargic. Child is going to be lethargic. Liver will be fatty. Because of the edema, the face becomes swollen, which is called moon-like facies, The weight will appear to be normal. Because of the water retention, Contrast this with marasmus. Because you have lost somatic protein, which is less important for survival, the overall prognosis improves because the neurotransmitters and enzymes are still there. So you have better prognosis. The appetite is there because the neurotransmitter enzymes are still there. The consciousness, the child is alert, or we can say the child is irritable. Or alert. Liver is going to be normal. Face, because of the loss of all the subcutaneous tissue and all the fat, there is going to be simian facies. The weight is going to be less. The weight is paradoxically normal in Kwashiorkor. Why? Because of the water retention, because of the loss of the albumin leading to edema. Okay. Then comes hair and skin changes. Again, the hair and skin changes basically denote a much more severe process. So the hair change of flaxine and flaky pain dermatosis, this is seen as far as Kwashiorkor is concerned, and this is not seen as far as marasmus is concerned. So this is what flaky pain dermatosis look like. This is what flaky pain dermatosis looks like. And this is what flaxine looks like. So what is basically flaxine? So you can have normal pigmentation, you can have dyspigmentation, so basically white, and then you again will have normal pigmentation. So this resembles that of flag. That's what's called a flaxine. Again, this will be seen as far as Kwashiorkor is concerned, and this is what flaky pain dermatosis look like. You will have normal pigmentation, dyspigmentation, and normal pigmentation looking like flakes of pain. That's why flaky pain dermatosis. Both the things will be seen as far as Kwashiorkor is concerned, won't be seen as far as marasmus is concerned. Alright, now moving on. Tell me the answer to this particular question. A child comes to you with following measurements. Weight for height is -1.7, height for age is -2.4. Child has. Tell me the answer to this question. Alright, the correct answer to this question is going to be option B, which most of you are telling. Ishita, why are you thinking acute on chronic? Alright, so it's going to be option 2. It's going to be chronic malnutrition, moderate chronic malnutrition. Now comes the next question. Which of the following is not SAM? Tell me the answer to this question. Tell me the answer to this particular question. Tell me the answer to this particular question. Tell me the answer to this particular question. Which of the following is not SAM? Alright, so most of you are answering it correctly. Height for age -3 standard deviation will not be categorized as SAM. So let's learn about this acute and chronic malnutrition and how we judge these and how we assess these. Alright, let's learn about this. Now, as far as acute malnutrition is concerned, listen to this very carefully. As far as acute malnutrition is concerned, acute malnutrition is best assessed by the best parameter for acute malnutrition is weight for length. It is what? Weight for length. The best parameter for length for chronic malnutrition is length for age. It is what? Length for age. Alright. Now, we all know from basic PSM that from +2 to -2 standard deviation, from +2 to -2 standard deviation is 95% of the population. And this is considered the normal population. This is considered a normal population. So as far as acute malnutrition is concerned, acute malnutrition will be defined as when the weight for length is less than -2 standard deviation. It is less than -2 standard deviation. If the weight for length is less than -2 standard deviation, we call it as moderate acute malnutrition. We call it as moderate acute malnutrition. We call it as moderate acute malnutrition. And if the weight for length, is less than -3 standard deviation, then we call it as SAM. That is your severe acute malnutrition. That is your severe acute malnutrition. That is your severe acute malnutrition. That is your SAM. Similarly, if the length for age is less than -2 standard deviation, we call it as moderate chronic malnutrition. We call it as moderate chronic malnutrition. We call it as moderate chronic malnutrition. And if the length for age is less than -3 standard deviation, it's less than -3 standard deviation, we call it as severe chronic malnutrition. We call it as severe chronic malnutrition. All right. Now, understand this very carefully. I already discussed. Let's say I don't take any food for next 1 week, or I know any one of you doesn't take any food for the next 1 week. My weight is, let's say, 70 kg. If I don't take any food for the next 1 week, what will happen? My weight will suddenly drop from, let's say, 70 kg to 65 kg. So what has come down? The weight has come down, right? Nothing has happened to my height. Same for a child. Let's assume a 3-year-old child. A 3-year-old child having a weight of 15 kg and a height of approximately, let's say, 90 centimeter or 95 centimeter. If that child acutely for next 2 weeks, 3 weeks doesn't take anything, doesn't have any food, what will happen? Will the height be affected? No, the height will stay the same, right? But the weight will drastically fall. The weight is going to drastically fall. The weight can directly go from 15 kg and it can directly become what? It can directly become 12 kg or 11 kg or even 10 kg. This is the reason for acute malnutrition. For acute malnutrition, we always prefer a weight-based parameter. And amongst weight-based parameters, we can use either weight for age or we can use weight for length. But weight for length is an age-independent parameter. We don't need to use age also. So weight for length in general is considered a better parameter. Weight for length is in general considered a better parameter. Now, as far as chronic malnutrition is concerned, we need something which is affected only chronically. And height is the only thing that gets affected over a long period of time. Weight can get affected both acutely and chronically, but height will only get affected chronically. This is the reason something which is more specific as far as chronic malnutrition is concerned, it is going to be your length. It's going to be your length. That's why the length for age or height for age is considered the best parameter. It is the best parameter as far as chronic malnutrition is concerned. So for acute malnutrition, weight for length. For chronic malnutrition, length for age. For chronic malnutrition, length for age. Then comes the concept of weight for age. Now, weight for that particular age, it's an indicator of, weight for age is an indicator of both acute and chronic. Both acute and chronic malnutrition. It's an indicator of both acute and chronic malnutrition. It's an indicator of both acute and chronic malnutrition. It's an indicator of both acute and chronic malnutrition. All right. Now, because weight for age is an indicator of both acute and chronic malnutrition, it is not the best parameter for either of them. Weight for length is specific for acute. Height for age is specific for chronic. Weight for age can be used for both acute and chronic, but since it can be used for both acute and chronic, it is not the best for either of them. It is not the best for either of them. It is not the best for either of them. Now, when this weight for age, if this weight for age is less than -2 standard deviation, we say the child is underweight. We say the child is underweight. We say what? We say the child is underweight. We say the child is underweight. Similarly, if the weight for length is less than -2 standard deviation at any given point of time, be it -2, -3, -3, everything, the entire broad category is called as wasting. And whenever the height for age is less than -2 standard deviation, it is called as stunting. It is called as stunting. All right. So something which gets affected acutely, it's only weight for length. Something which gets affected chronically is only, specifically it is height for age. Something which gets affected both acute and chronic, it's weight for age. Because weight for age gets affected both in acute and chronic parameter, both in acute and chronic malnutrition. That is the reason it is not the best. That is the reason it is not the best for either of them. Because the best parameter will be specific for that particular category. The best parameter will be specific for that particular category. As far as acute and chronic malnutrition is concerned, in acute and chronic malnutrition, height for age will also be low and weight for length will also be low. Weight for length will also be low in acute and chronic. For acute and chronic, what will happen? For acute and chronic, let me explain this with the help of an example. Let it take 10 extra minutes, doesn't really matter. You will easily understand with the help of this example afterwards. Let's assume a 2-year-old child. Let's assume a 2-year-old child. Let's assume the weight of this 2-year-old child is 12 kg. And let's assume the height of this 2-year-old child is approximately 87 centimeter. It is what? 87 centimeter. Alright. Let's first make this child acutely malnourished. Let's make this child acutely malnourished. Okay. So let's say for the next 1 month, the child did not have anything. The child did not have anything. Food nahi liya, usne kuch nahi liya. What will happen? The weight of the child will fall. The weight of the child will fall. The weight of the child will become what? Let's say the weight of the child becomes 9 kg. Let's say the weight of the child becomes 9 kg now. What will happen to the length? The length will stay the same. The length will stay the same. It will still be 87 centimeter. It will still be 87 centimeter. So in acute malnutrition, this is an example of acute malnutrition, right? In acute malnutrition, what if we look closely, what has happened? Weight for length. For the 87 centimeter length, the weight should be 12 kg. For 87 centimeter length, the weight should be 12 kg. Now for that 87 centimeter length, the weight has fallen. The weight has fallen. That has become from 12 to 9 kg. So the weight for length has actually decreased. Weight for length has actually decreased. Let's look at height for age. A 2-year-old child having 87 centimeter height, 2-year-old 1 month child having 87 centimeter height. It's one and the same. Nothing too much of a difference is not there. Maybe a minor fall. So overall the height for age stays normal. So in acute malnutrition, height for age is not affected. Then let's look at weight for age. As far as weight for age is concerned, for a 2-year-old child, the weight should be 12 kg. Now for a 2-year-old 1 month child, the weight should be 13 kg, but it has fallen. So weight for age has also fallen. Weight for age has also decreased. So with this, it's very clear that in acute malnutrition, we cannot use height for age. We either have to use weight for length or we have to use weight for age. We have to use weight for age. Now let's take the example of a chronic malnourished child. Again, let's assume a child of 2 years of age. Let's say the weight of this child again is 12 kg and the height is 87 centimeter. Now I'm going to make this child chronically malnourished. So let's say for the next 1 year, he's not taking food adequately. So that after 1 year, after chronic malnutrition, after 1 year, the height has not grown at all. So height is still 87 centimeter. Obviously, because the boy was not taking any food, the weight also did not grow. The weight also stayed exactly the same. It did not decrease, it did not increase. Let's say it stayed the same. It stayed what? It stayed 12 kg. It stayed exactly the 12 kg. Now let's look at the parameters here. Has the height for age decreased? Yes. 87 centimeter height was normal for 2 years, but 87 centimeter height for 3 years is definitely low. So height for age has decreased. Height for age has decreased. Is the weight for age low? Yes. A 2-year-old child having 12 kg weight is normal, but a 3-year-old child having 12 kg weight is definitely abnormal. So weight for age has also decreased. But look carefully at weight for length. If we look carefully at weight for length, for 87 centimeter, the weight was 12 kg. Again, for the ratio is maintained the same. For 87 centimeter, the weight is still 12 kg. So in chronic malnutrition, the weight for length can actually be normal. Now with this, let's see what we just discussed. Which is the thing which is getting reduced only in chronic malnutrition? The answer to that question is height for age. Height for age was normal in acute. Height for age was normal in acute, but height for age was decreasing only in chronic malnutrition. Only in chronic malnutrition, the height for age was getting reduced. This is the reason that for chronic malnutrition, the best parameter is height for age. Now let's look at acute the parameter which was getting reduced only in acute malnutrition. If we look at that, only weight for length was getting reduced in acute malnutrition. Weight for length was reduced in acute malnutrition. Weight for length was normal in chronic malnutrition. The only parameter which was getting reduced only in acute malnutrition, which was specific for acute malnutrition, was weight for length. It was weight for length. And let's look at this very carefully. Weight for age was decreased in acute malnutrition also. Weight for age was decreased in chronic malnutrition. Now, because weight for age is decreased in both acute and chronic malnutrition, it is not the best parameter for either of them. It is not the best parameter for either of them. So we can say, right, that for acute malnutrition, the best parameter is weight for length. For chronic malnutrition, the best parameter is the length for age or height for age. It is what? Length for age and height for age. Now coming to the question, how do we assess for acute and chronic malnutrition? Now as far as acute and chronic malnutrition is concerned, the height for age should be decreased. Because it is chronic malnutrition, and because it is acute malnutrition, the weight for length should also be decreased. When these two things are there, then we can say it is acute on chronic malnutrition. If only height for age is decreased, it is chronic malnutrition. If only weight for length is decreased, it is acute malnutrition. If both height for age and weight for length is decreased, then only we can say it is what? It is acute on chronic malnutrition. I hope you guys have understood that why we use weight for length only for acute, why we use height for age only for chronic, why weight for age can be used for both. That's why it is not the best parameter for either of them. Alright. Now, so in chronic malnutrition, weight for length or weight for height can be normal. Moving on towards SAM. How do we define SAM? SAM is defined as any one of the following. Severe acute malnutrition is defined as any one of the following. If the weight for length is less than -3 standard deviation, or mid upper arm circumference is less than 11.5 centimeter, or there is visible severe wasting, or there is bipedal nutritional edema. Alright, any one of the following, you will say the child is having SAM. There is a logic why the SAM definition was made such. If you look closely, first two parameters, both are age independent. We don't need to know the age of the child, but we can still say the child is having severe acute malnutrition. Weight for length is an age independent parameter. Similarly, mid upper arm circumference is also an age independent parameter. So if the mid upper arm circumference is low or weight for length is low, we can easily say the child is having SAM. The reason option 3 and option 4 are there is because of marasmus and kwashiorkor. See, if a child is having kwashiorkor, because of the child having kwashiorkor is a very severe form of acute malnutrition. It's protein and energy malnutrition. It obviously should be classified as severe acute malnutrition also. But in kwashiorkor, because when you have lost so much of albumin and there is water retention and weight gain, your weight for length can falsely be normal. Alright. And similarly, your mid upper arm circumference, because of the water retention, can also falsely be normal. So in order to ensure that a kwashiorkor child is always classified as having severe acute malnutrition, that you don't end up saying that a kwashiorkor child is normal, that is the reason the definition of SAM has bipedal nutritional edema. To ensure that a child with kwashiorkor is always classified as having SAM. Alright, so this is the reason why we have this definition of SAM. Weight for length less than -3 standard deviation, or mid upper arm circumference less than 11.5 centimeter. Both of them which are age independent parameter. Visible severe wasting, to ensure marasmus is there, to ensure we classify a child with marasmus as having SAM, and bipedal nutritional edema, to ensure that we classify a child with kwashiorkor having SAM. to ensure that we don't falsely say that a child with kwashiorkor is actually good nourished or normally nourished. Okay, now coming to the complications of SAM and the management of SAM, the complication and management of SAM. So you have to understand, as far as the complications and the management of SAM is concerned, that the management of SAM is broadly divided into two main phases. It is broadly divided into two main phases. It's divided into a stabilization phase and a rehabilitation phase. The stabilization phase lasts for the first 7 days. It lasts for the first 7 days. Alright. And the rehabilitation phase is after, it is beyond the first 7 days. The rehabilitation phase is, the rehabilitation phase is beyond the first 7 days. It is beyond the first 7 days. Okay, the rehabilitation phase is beyond the first 7 days. The concept basically goes that the child who has come to you with SAM, because of the complications of SAM, the child can actually die within the first 7 days. So the first 7 days are used to stabilize the child so that he doesn't die. The entire concept of the first 7 days is, okay, don't let the child die. मरना नहीं चाहिए. हाँ, जब पहले 7 दिन में हमने उसको जिंदा कर लिया, in the first 7 days when we have ensured that the child is alive, only after that do we build that child up. Only after that do we build that child up. Building up is what is called as rehabilitation. That's why rehabilitation comes after the first 7 days. That's why in the first 7 days, in the first 7 days in the stabilization phase, what we are doing, we are ensuring the child is not dying from hypoglycemia, not dying from hypothermia, not dying from infection. These three things form a triad. And tend to occur together. Obviously, a child can die from electrolyte abnormality. Particularly in these children, they have hypokalemia and hypomagnesemia. So ensure that you supplement potassium. You ensure that you supplement magnesium. They also have hypernatremia. So ensure that you properly supplement potassium and magnesium, and you don't give too much of sodium. Again, dehydration can kill. That's why we are ensuring that the child is stabilized from dehydration within the first 3 days itself. So hypoglycemia management, hypothermia management is the first 3 days itself. Infection obviously takes some time to resolve. So we are going to give what? We are going to give IV antibiotics for 7 days. Which IV antibiotics? Ampicillin plus gentamicin. So child is going to have a lot of micronutrient deficiency. We are going to supplement all the micronutrients except iron. We do not give iron in the first week. No iron in first week. And beyond first week, we can consider giving iron also. The logic behind this is that iron will result in a lot of free radical generation, which can kill the child during the initial stabilization phase, which will aggravate the infection, which will aggravate the free radical formation during the first week by the infection also. That is the reason we do not give iron in the first week. Beyond first week, we can consider giving iron. Then comes cautious feeding and catch-up growth. As far as cautious feeding is concerned, cautious feeding will stay till the first week. And it won't go beyond that. It will stay till the first. Cautious feeding is till the first week, while catch-up growth is going to be happening beyond. Catch-up growth will actually happen beyond in the rehabilitative phase. In the cautious refeeding phase, we are not going to give too high calorie protein. We are not going to give too high calorie diet. We are just going to give F75. During the catch-up growth, we are going to give F100. Now, why is this cautious feeding done? It is done to prevent refeeding syndrome. Now, what is this refeeding syndrome? If in the first week itself, you give a very high calorie food or a very high protein food to the child, what will happen? The child has not taken anything. Child is having SAM. Child has basically become hibernated to any form of food, right? Now, suddenly, if you give them a very high calorie food or a very high protein food, it's going to result in a very high insulin levels. High calorie, insulin gets secreted a lot. What will this insulin do? Insulin will do what? It will transport all the potassium from outside inside the cell. It will transport all the phosphate from outside into the cell. This will result in hypophosphatemia. And hypokalemia. If you give a very high calorie food. That's why in the first week we give cautious refeeding. And we do cautious refeeding in order to prevent what? In order to prevent this refeeding syndrome. If you give a very high calorie food, high insulin will result in this hypophosphatemia and hypokalemia. The hallmark of refeeding syndrome, is hypophosphatemia. It is what? It is hypophosphatemia. All right. Okay. Now comes, doesn't the free radical supposed to kill the microorganism? Okay, actually, as far as the free radicals are concerned, organisms, particularly the gram-negative organisms, your E. coli, your Klebsiella, and all these gram-negative organisms, they actually thrive on iron. In fact, things which bind iron, like lactoferrin, which is present in milk, it actually prevents infections against E. coli. So iron actually aids the growth of microorganisms, particularly the gram-negative microorganism which cause SAM infection. That is the reason, that is also one of the reasons why iron is not given during the first week. One part is free radical, the other part is also that it actually aids the growth of microorganisms in the first week, particularly the gram-negative organisms which are more common as far as your SAM is concerned, I hope that clears your doubt. What's his name? Dr. L. I hope that clears your doubt that why don't we give iron in the first week. One, free radical is going to be damaging to the body. Excess of free radical is going to be damaging to the body. And the iron in itself can act like a source. For the gram-negative organisms in particular. Alright. After this we are coming to milestones only. Don't worry about that. I'll help you remembering all the milestones. Alright, don't worry about that. Now, how do you assess for response? As far as SAM is concerned? So we can have primary failure of SAM management or we can have secondary failure. Primary failure is assessed on day 4. It is assessed on day 4 and it is assessed on day 10. Primary failure is assessed on 2 days, either on day 4 or on day 10. We say it is primary failure if there is failure to begin to lose edema. Alright. Sham, it is not an already recorded video. What do you want me to do? Do you want me to come on Instagram live? Anyhow, primary failure is on day 4 when there is failure to begin to lose edema or failure to regain appetite This is what we say as far as primary failure is concerned. On day 4. On day 10, we'll say primary failure has occurred if there is presence of any edema. Or there is failure to gain weight at 5 gram per kg per day for 3 consecutive days. So primary failure is assessed on 2 days, day 4 and day 10. On day 4, we'll say primary failure has occurred if there is failure to begin to lose edema, some edema should be lost, or failure to regain the appetite. On day 10, we'll say the primary failure has occurred if all edema is not lost or there is failure to gain weight at 5 gram per kg per day. As far as secondary failure is concerned, secondary failure is that at any later time point, at let's say day 20, day 30, when primary failure hadn't occurred, at day 20, day 30, day 40, during that particular time point, there is failure to gain weight at 5 gram per kg per day, for 3 consecutive days. That's when we'll say that there is a secondary failure. So primary failure is assessed on 2 days, day 4, day 10. If primary failure doesn't occur and at a later time point, day 20, day 30, you again have 3 days when you're not gaining adequate weight. You're not gaining weight at 5 gram per kg per day. That's when you'll say that the secondary failure has occurred. Now moving on towards vitamin, only 2 vitamins I'll discuss in depth because most of them would have been done in biochemistry as well. I'll just discuss vitamin C, which is a water soluble vitamin, and I'll discuss vitamin D deficiency. That's a little bit of your rickets. Okay, let's revise them. And then we'll move towards the most important part, that is your milestones. And I'll ensure that you guys remember milestones in a most fun and crisp manner. Most of the milestones will become very easy. Just bear with me for the next 4-5 minutes as we discuss vitamin C deficiency, that is your scurvy, and as we discuss vitamin D deficiency, that's your rickets. Okay. Now, as far as vitamin C is concerned, the deficiency, we all know vitamin C is what? It's ascorbic acid. It is ascorbic acid. That is ascorbic acid. All right. And the main function of this ascorbic acid in our body is what? It is hydroxylation. It is hydroxylation of lysine and proline residues. It is hydroxylation of lysine and proline residues in collagen. It is the hydroxylation of lysine and proline residues in collagen. It is a hydroxylation of lysine and proline residues in collagen. So if vitamin C deficiency is going to be there, what is essentially going to happen? Collagen is not going to get made. And if collagen doesn't get made, wherever collagen is there in the body, collagen deficiency signs and symptoms are going to happen. That is what is going to happen as far as scurvy is concerned. That is what is going to happen as far as scurvy is concerned. That there is essentially going to be collagen deficiency. So collagen is where? Collagen is there in our gums. If collagen is not there, the gums are not going to have their structural integrity. They will start to bleed. So there is going to be what? There is going to be bleeding gums. There is going to be bleeding gums. Collagen is there in our skin. If the skin structural integrity, the subcutaneous tissue structural integrity is not there, what is going to happen? Petechiae is going to occur. What is going to occur? Petechiae is going to occur. Similarly, collagen is there in joints. So there's going to be a lot of joint bleeds as well. There's going to be a lot of joints and bone bleeds as well. There's going to be joint bleed and bone bleeds as well. Bone bleeds as well. And this is what is responsible for the scorbutic rosary. This is what is responsible for the scorbutic rosary. What happens in scorbutic rosary? There is essentially a lot of bleeding at the ribs. There is essentially subperiosteal hemorrhage. There is essentially what? There is subperiosteal hemorrhage in ribs. There is essentially subperiosteal hemorrhage in ribs. So when there is subperiosteal hemorrhage in ribs, the blood is going to accumulate in the ribs. It's going to accumulate in the ribs and is going to form these bead-like structures, which is basically called the scorbutic rosary, Obviously, if it is bleeding, it's going to be very, very painful. It's going to be very, very painful. So scorbutic rosary is bead-like structure because of the subperiosteal hemorrhage in the ribs, and it's very painful. It's angulated also. It's painful and angulated. All right. And as far as the X-ray changes, in scurvy are concerned, what will happen? There is going to be subperiosteal hemorrhage. The hemorrhage, if you know from your path, whenever there is hemorrhage, there is going to be calcification. So there is going to be dense calcification. There is going to be a dense zone of calcification. All right, dense zone of calcification, which is called as white line of Frankel. And just above that dense zone of calcification, there is going to be a zone which is going to be completely black. This is called scorbutic zone. Along with that, you will have ring-shaped epiphysis and a spur. A growth in a outwardly direction, which is called a spur. This is called a Pelkin spur. So these are the characteristic changes you will see as far as X-ray of scurvy is concerned. You will see what? You will see subperiosteal hemorrhage. You will see white line of Frankel because of the calcification. You will see white line of calcification. You will see a scorbutic zone just above that. You will see ring epiphysis and you will see a Pelkin spur. So these are the X-ray changes that you will see as far as a patient with scurvy is concerned. Now let's move on towards vitamin D deficiency. That is rickets. So in rickets, there are going to be two main set of changes as far as two main sets of organ system, or let's say the areas of organ which are going to get affected. One is your chest, other one is your legs. As far as chest is concerned, what happens in rickets? What happens in vitamin D deficiency? So vitamin D in our body is required for calcium phosphate absorption. And this calcium phosphate, after it is absorbed, it is deposited in bones. It is done what? It is deposited in bones. It is deposited in bone, which is the process which is called as mineralization. This is the process which is called as mineralization. This is the process which is called as mineralization. So what will happen in vitamin D deficiency? This calcium phosphate absorption won't take place, and this mineralization and deposition in growing bones won't take place. This is what will happen, especially as far as vitamin D deficiency or rickets is concerned. If there is improper mineralization of the ribs, what will happen? The ribs will lack the structural integrity. They will lack the structural integrity. So whenever you are inspiring, what will happen? You will end up having a sulcus formation. You will end up having a depression there. This is what is referred to as Harrison sulcus. This is what is referred to as Harrison sulcus. Apart from Harrison sulcus, what will happen? Since the ribs are not properly mineralized, the calcium deposition, the phosphate deposition in the ribs has not occurred properly, the costochondral junction, which will have a lot of cartilage, that cartilage will expand. And the expansion of that cartilage results in the formation of the rachitic rosary. It results in the formation of the rachitic rosary. So why does rachitic rosary occur? Because the cartilage at the costochondral junction, it is not calcified properly, so that cartilage expands. So this is because of increased costochondral junction. This happens because of increased costochondral junction cartilage. Alright, the cartilage expansion. Why the cartilage expansion occurs? Because there is no calcification. Now obviously, because the rachitic rosary, simply because cartilage is extra cartilage is being formed, that's why the rachitic rosary is usually painless. It is painless. Contrast this with the scorbutic rosary, which I just talked about. Scorbutic rosary is because of bleed, very painful. Rachitic rosary, just the cartilage has expanded. That's why painless. The other sets of changes as far as rickets are concerned will occur in limbs. They will occur where? They will occur in limbs. They will occur in limbs. As far as limbs are concerned, you can have knock knees. That when the limbs are being formed, they are not able to bear the upper segment weight, so they bend and they start to knock with each other. The knees start to knock with each other. This is called as genu valgum. This is also called as genu valgum. Or you can have bow legs. This is what is called as genu varum. The third thing is you can have genu varum in one leg and genu valgum in another. This looks like as a wind has come and swept the legs like this. This is what is called as wind swept deformity. This is what is called as wind swept deformity. Alright. Now what will be the X-ray changes as far as rickets are concerned? The first change in X-ray in rickets. Is concerned. So I told you, what is the main function of vitamin D? It is calcium and phosphate absorption and deposition and the mineralization of the growing bones. So this calcification of bones is the first thing that will be lost. So it will be loss of provisional zone of calcification. That will be the first sign of rickets. There will be loss of provisional zone of calcification. That will be the first sign of rickets. The other X-ray changes, they will be like as follows. The metaphyses will become cup shaped. They will become what? Cup shaped. This is what is referred to as cupping. Alright. Along with that, what will happen? The ends will be frayed. Frayed is frizzy hair. The ends will be frayed because again proper calcification is lacking. This is called as fraying. And then again a growth will occur in a wrong direction. The calcification occurs in a wrong direction. This is what is called as splaying. So cupping, splaying and fraying. So cupping, splaying and fraying are the other X-ray changes that will occur as far as rickets is concerned. What will the lab investigations show? So first thing you have to understand the calcium. If vitamin D is not there, what is going to happen? Calcium absorption is going to get affected. There is going to be less calcium which is absorbed. So calcium can be low. But whenever calcium gets low, what happens? Whenever there is low calcium, It stimulates what? It stimulates PTH. PTH causes bone resorption. PTH causes bone resorption. It causes bone resorption and again increases calcium. So again increases calcium. So what will happen to calcium? Calcium, either it can be low, but sometimes it can be normal also. It can sometimes be normal also because of the action of PTH. So what will happen to PTH? What will happen to PTH? PTH will always be high. Because the second calcium goes low, PTH becomes high. PTH becomes high. The third thing, what will happen to phosphate? What will happen to phosphate? So phosphate is not getting absorbed. PTH also excretes phosphate. PTH is a phosphaturic hormone. So phosphate always will be low. Phosphate always will be low. The fourth thing is your alkaline phosphatase. So alkaline phosphatase is a marker of bone resorption or bone activity. So PTH will act on bone, cause bone resorption to increase the calcium. So bone resorption will occur. So alkaline phosphatase levels will also be high. Alkaline phosphatase levels will also be high. So this will be as far as your lab investigation in rickets is concerned. If I ask you a question, should you measure 25 hydroxy vitamin D levels or should you measure 1,25 hydroxy vitamin D levels? Which level should you measure in order to detect vitamin D deficiency? The answer is going to be 25 hydroxy vitamin D. Why? Because this is a storage form. So in vitamin D deficiency, the storage form will always be low. Well, this is the active form. And it can falsely be high. Due to PTH action. Whenever PTH becomes high, it causes more activation of 1,25 OH vitamin D. So active form can sometimes falsely be high. But the storage form will always be low. Because you're not taking any vitamin D. That's why to detect vitamin D deficiency, we do what? We always do 25 OH vitamin D levels. Alright. With this, let's take a 1 minute, 2 minute breathe and let's come to the most important topic that we'll discuss. That is your milestones. Alright. That is your milestones. So yes, absolutely. So Megha, the first clinical sign, X-ray is a lab investigation. The first clinical sign is craniotabes. The first lab investigation is loss of provisional zone of calcification. I hope that clarifies your doubt. The first clinical sign in case of rickets is craniotabes, the ping pong skull. I did not talk about it because I assume that this is something which you all will already know. But since you are having a doubt, let me clarify it for you. The first clinical sign, what you will see clinically. Clinically, would you do an X-ray first? No, you'll see the child, right? So clinically, the first sign is craniotabes. The first lab investigation sign is loss of provisional zone of calcification. I hope that clarifies. Anushka, I can teach refractory rickets. It's not that I cannot teach refractory rickets, but this is a revision class. So I would rather focus on more important refractory. I would rather focus on milestones at this particular point of time than going into the depths of refractory rickets, because that would take a proper explanation of refractory rickets would require at least half an hour. If not half an hour, at least 20 minutes, in which I can actually revise multiple other topics. So I would rather focus on milestones rather than going on refractory rickets. All right. Sure, let me explain this once more. If vitamin D is not there, what will happen? Calcium levels will go down. Fair enough. So calcium levels in vitamin D deficiency can be low. But the second vitamin D calcium levels start to go low, it starts to stimulate what? Parathyroid hormone. We all know parathyroid hormone wants to increase calcium levels in the body. So if the calcium levels go low, the PTH levels become high. When the PTH levels become high, they will cause bone resorption. PTH will cause bone resorption and will bring back the calcium levels to normal. It will bring back the calcium levels to normal. So calcium levels can either be low or it can be normal. PTH levels are always high. Now, PTH in our body has two functions. It increases calcium and it decreases phosphate. It decreases phosphate. It increases calcium and it decreases phosphate. So phosphate levels, because the PTH is high, phosphate levels will be low. Phosphate levels will be low because PTH is high. The second reason why phosphate levels are low is because, again, vitamin D is not there. Vitamin D is responsible for phosphate absorption. So phosphate is not getting absorbed. That's why phosphate levels are low. And whatever phosphate also was there was getting excreted out, was getting low by which hormone? By this PTH, because PTH has become high. Because this PTH has become high. That's why phosphate is always low as far as vitamin D deficiency rickets is concerned. As far as vitamin D deficiency rickets is concerned. Alright. Now let's move on towards the most important topic. That is your milestone. Let's revise the milestones in a easy and fun-based manner, I would say. As far as milestones are concerned, I would simply ask you guys to draw a stick figure. To simply draw a stick figure. After you have drawn this stick figure, most of the milestones will become easy. They will actually become easy. Especially the gross motor milestones, they will become very, very easy. Okay. A child will gain neck control. Draw a stick figure and draw some lines like these. Draw 4 lines like these. 4 lines like these. These 4 lines represent 3, 6, 9 and 12. They represent what? 3, 6, let me stand up a bit so that it's easier for you guys to remember. Alright, 3, 6, 9. 9 is what? Knees. And 12 is what? It is your feet. 12 is what? It is your feet. 3 for neck, 6 for your trunk, 9 for knees, and 12 for your feet. If you remember this, milestones are easy. So at 3 months, what will you have? At 3 months, you will have neck control. You will have your neck control, head control, whatever you want to call it. At 6 months, trunk. So child will be able to, trunk control is this, child will be able to sit with support. Child will be able to do what at 6 months? Sit with support. So at 6 months, trunk control starts, so child will be able to sit with support. When a child sits with support, he sits with his own hands. So this is also called as tripod position. At 9 months, the knees are strong. At 9 months, the knees have become strong. So child will be able to stand with support at 9 months. So child is able to stand with support at 9 months. And then finally at 12 months, the feet have become strong. If the feet have become strong, the child will be able to walk with support. Child will be able to walk with support. Alright. So 6, sit with support. 9, knees, stand with support. 12, feet, walk with support. If you are doing a milestone which is with support, the prior milestone, if you are walking with support, walking with support will only start if you are able to stand independently. The prior milestone without support should have occurred. So if you are able to stand with support at 9 months, child will be able to sit without support. Sit without support at 8 months. If child is able to walk with support at 12 months, child should be able to stand without support at 12 months. Child should be able to stand without support. At 12 months. Alright. So 6 months, 6 for trunk, 9 for knees, 12 for feet. 6 months, sit with support. 9 months, stand with support. 12 months, walk with support. So if 12 months walk with support, so stand independently will occur simultaneously. At 9 months, if he is able to stand with support, at 8 months, sit without support should have occurred. And at 8 months, sit without support should have occurred. And at 6 months, the child always was sitting with support. Alright. I hope you have understood. 6 months, this, 9 months, knees, 12 months, feet. So at 6 months, sit with support. 9 months, stand with support. 12 months, walk with support. If at 12 months, child is walking with support, child should be able to stand independently, that is stand without support. At 9 months, if child is standing with support, prior to that, he should be able to sit without support. That's why at 8 months, child is able to sit without support. And at 6 months, obviously sitting with support is there. Obviously sitting with support is there. Obviously sitting with support is there. So that's how you can easily remember the milestone, especially the gross motor milestone. Especially the gross motor milestone. I hope you have understood. If you have understood, please put a thumbs up. If you have understood this. 3, 6, 9 and 12. 3, 6, 9 and 12. 6, trunk, sit with support. 9 months, knees, stand with support. 12 months, feet, walk with support. Okay? I hope people don't forget it now. I hope people don't forget it now. Hope people don't forget it now. Alright. Apart from this, you just need to remember 2 or 3 extra milestones at 2 or 3 given time points. At 5 month, child rolls over. At 5 month, child rolls over. At 8 month, child crawls. And at 10 month, child creeps. At 10 month, child creeps. So crawling is when the child is touching the abdomen is touching the ground. Abdomen is touching the ground, that is crawling. If the abdomen is above the ground, that is called as creeping. So obviously above the ground will occur later. So crawling occurs at 8 months. Crawling occurs at 8 months. While creeping occurs at 10 months. Creeping occurs at 10 months. Alright, creeping occurs at 10 months. Alright. So at 12 months, what was happening? 12 months, walking with support was happening. Walking with support was happening. So at 15 months, what will happen? Walking without support will happen. After 15 months, what will happen? Walking without support. Walking without support. मैं चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना चाहता हूं. That's what Ranbir Kapoor said in Ye Jawani Hai Diwani, right? That I want to walk, I want to run, and I want to fly. So that's what the child will also do. Child started to walk at 15 months. So at 18 months, child will start to run. And at 24 months, the child will start to fly. Obviously, the child will not fly. Child will do what? Child will be able to walk up and down stairs. Child will be able to do what? Walk up and down stairs. Up and down stairs. So up and down stairs will start at 2 years of age. Up and down stairs will start at 2 years of age. Initially at 2 years of age, when the child is going up and down stairs, he is going to use both the feet. So he'll use one feet and then another feet on the same step. So this up and down stairs initially at 2 years is 2 feet at a step. It is 2 feet at a step. At 3 years of age, what will happen? 3 for tricycle. Child will be able to ride a tricycle. Child will be able to ride a tricycle. Now the child will be able to go upstairs. 1 feet at a step, 1 feet per step. But child will come downstairs. Child will come downstairs 2 feet per step. Child will come downstairs 2 feet per step. Because coming down, the child can fall. So coming down is a tougher task. So at 3 years of age, child will be able to go upstairs at 1 feet per step. But coming downstairs, he will require 2 feet. Coming downstairs, he'll require 2 feet so that he doesn't fall. At 4 years of age, he'll be able to go both up and down stairs, 1 feet per step, 1 feet per step, 1 feet per step. And at 4 years, 4 has 4 words in it. Hops also has 4 letters in it. Hops also has 4 letters in it. So child is able to hop at 4 years in it. 5 has 5 in it. Skips also has 5 letters in it. So child will be able to skip at 5 years of age. So hops at 4 years, skips at 5 years. With this, we complete the gross motor milestone. Just remember the 6, 9 and 12 dictum. 6 is sit with support, 9 is stand with support, 12 is walk with support. 12 months walk with support, 15 month walk without support, 18 month run. मैं चलना चाहता हूं, मैं दौड़ना चाहता हूं, मैं उड़ना चाहता हूं. So 18 months he's running. So 2 years he'll be able to go up and down stairs. He'll be able to go up and down stairs. Initially 2 feet at a time. At 3 years, 3 for tricycle. 3 for tricycle. At 3 years, he will be able to go up feet, 1 feet at a time, but downstairs because he can't fall 2 feet at a time. 4 for hops. 4 letters in hops. 5 for 5 letters in skips. So child is able to skip at 5 years of age. Child is able to skip at 5 years of age. Alright. Cruise. What is cruising? Someone asked cruising. I was going to come to cruising. Cruising is when he's using the furniture to walk. He's using the furniture to walk. Okay, so cruising is basically a type of walking with support. It's a type of walking with support. Walking with support comes at 12 months of age, but when we talk about walking with support, we take the support of the hands of our parents. That is what is considered walking with support. Walking with the support of furniture is what is called as cruising. So it will come just prior to the actual walking with support. That's why cruising comes at 10 to 11 months. It comes at 10 to 11 months. The walking with support is coming at 12 months. That is the actual walking with support, with the support of the hands of your parents. Cruising is walking with the support of furniture. Will come just prior to the 12-month point. So it will come at 10 to 11 months. It will come at 10 to 11 months. Alright. So Ishita, you're absolutely right. Cruising at 10 to 11 months. Cruising at 10 to 11 months. Next comes the fine motor milestone. Next we come to the fine motor milestones. Now as far as the fine motor milestones are concerned, at 3 months what will start to happen? Child will start to bring both the hands into the midline, and he'll start to look at both of his hands very intently. This is also what is called as hand regard. So at 3 months, child brings hands into midline. Child brings the hands into midline. Okay. At 3 months, he has gotten into midline. So at 4 months, he'll try to grasp an object. At 4 months, if there is an object here, he'll try to grasp it, but he will overshoot. So at 4 months, he'll try to grasp the object with both the hands. So this is what is called as bidextrous grasp. So at 4 months comes your bidextrous grasp, but he will overshoot. At 5 months, the bidextrous grasp with no overshooting. So if they ask you, when does bidextrous grasp start? It starts at 4 months. It is mature by 5 months. 6 months. So 4-5 months is bidextrous. At 6 months, he'll start to hold an object with single hand, but he will hold with the ulnar aspect of the hand. So 6 months will be ulnar grasp. Which is unidextrous. At 7 months, he'll start to use the radial aspect of the hands. So radial grasp will develop. At 9 months, immature pincer grasp comes. What comes? Immature pincer grasp. And at 12 months, finally, the mature pincer grasp comes. Now, what is the difference between this immature and mature pincer grasp? So at 6 months, let's take this object for an example. At 6 months, there was what? Ulnar grasp. He was holding it from the ulnar aspect of the hand. At 7 months, it became the radial grasp. He was holding it with the radial aspect of the hands. In immature grasp, if there is a small object, a small pellet, or let's say assume this pencil, he will hold it with the pincer. Pincer means the thumb and the index finger. But since it is immature, he will require the support of the middle finger. So middle finger support is required. So that is immature. He is able to pick it with just the thumb and the index finger. That will be mature pincer grasp. So mature pincer grasp will come at 12 months. Immature, when he's picking with thumb and index finger, but taking the support of a little support of the middle finger, that is called as immature pincer grasp. So at 12 months, he has mature pincer grasp and he has picked up a pen. So finally at 15 months, what he will start to do? When he has picked up a pen, at 15 months, he will start to do like this. So this is what is called as scribbling, and the scribbling comes at 15 months of age. Now we move on to the drawing skills. At 2 years of age, child will be able to draw a line between 2 points. 2 years, 2 points. 3 years of age, child will be able to draw a circle. You can remember that 3 has a circle in it. At 4 years, child will be able to draw a cross. So this is a cross. Cross has a 4 in it. At 4.5 years, child will be able to draw a square or a rectangle. At 5 years, child will be able to draw a triangle. This is what? This is a cylinder. This is what? This is a cylinder. Child will be able to draw a cylinder at 9 years of age. At what? 9 years of age. And this is what? This is a cube. This is a cube. Child will draw a cube at 11 years of age. At 11 years of age. So this is as far as the drawing skills are concerned. Another important drawing skill, this is what? This is a diamond. This is a diamond. So diamond has 7 letters in it. Diamond has 7 letters in it. Child will be able to draw a diamond at 7 years of age. At 7 years of age. At 7 years of age. Alright. So this is how you can remember the drawing skill. 2 years between 2 points, a line. 3 years, a circle. 3 has a circle in it in between. 4 years, a cross. So 4 has a cross in it. 4.5 years is rectangle, triangle. Rectangle and square. 5 years is triangle. 7 years, diamond has 7 letters in it. So diamond at 7 years of age. Cylinder, 9, and cube at 11. Cube at 11. Then coming to the towers and the cubes. The cubes, putting cubes on top of each other to make a tower. He's able to make a tower of 2 cubes at 15 months. He's able to make a tower of 6 cubes at 2 years. He's able to make a tower of 9 cubes at 3 years. At 3 years. Alright. So this is as far as the tower building skill of a child is concerned. Then coming to the dressing and undressing part. Dressing and undressing. Now as far as dressing and undressing is concerned, just remember that if you are with your girlfriend or if you are with your boyfriend, for the girls, if you go to a room, if the room is locked, what will happen? Is it easier to dress or is it easier to undress? It's very easy to undress. The same is valid as far as kids are also concerned. It's always easier to take out your clothes than to put on your clothes. Alright, that's why undressing will start earlier as compared to dressing up. Undressing will start earlier as compared to dressing up. Alright, the same thing is valid as far as children also are concerned. So child will be able to undress with help. Child will be able to undress with the help at 2 years of age. Child will be able to dress with help at 3 years of age. So if child is dressing with help, child will be able to undress without help at 3 years of age. So undress without help at also at 3 years of age. Also at 3 years of age. Child will be able to button himself up without any help. Buttoning without any help. Without any help at 4 years of age. At 4 years of age. At 4 years of age. And child will be able to dress fully without help. Child will be able to dress fully without any help. This includes your shoelaces. This includes your shoelaces at 5 years of age. At what? At 5 years of age. At 5 years of age. Now moving on towards the social milestones. At 2 months, child has what is called as a social smile. Child has a social smile. So at 3 months, he was able to look at both of his hands and that was called as hand regard. He has one other regard at the 3 months of age, that is mother's regard. He'll be able to regard his mother, that is able to recognize his mother. So at 3 months, child is able to recognize his own mother. Child is able to recognize his own mother. Okay. At 6 months of age, so 6 has 6 words in it, 6 in it, right? Mirror also has 6 letters in it. Mirror also has 6 letters in it, right? So mirror play will start at 6 months. Mirror play will start at 6 months. At 7 months, 7 has 7 in it. Anxiety. Anxiety also has 7 letters in it. Stranger anxiety will come at 7 months. Stranger anxiety will come at 7 months. Stranger anxiety will come at 7 months. 9 months. 9 has 9 in it. Bye. Also has 9 letters in it. Bye. Three times bye. So child will be able to wave bye. Child is able to wave bye. At what? At 9 months of age. At 9 months of age, another thing happens. 9 has 9 letters in it. Permanent also has 9 letters in it. Permanent also has 9 letters in it. Object permanence occurs at this particular point of time. Object permanence occurs at 9 months. What is object permanence? that prior to 9 months, if you take some object away from the field of vision of the child will be like out of sight, out of mind. He won't care. But after 9 months, if you take an object of interest, if you take the ball that he was playing with away from his sight, he will try to look around, because now the object is permanent. He knows that the object is somewhere around. That the object is permanent, is in his memory. So this object permanence will come at 9 months of age. This object permanence will come at 9 months of age. At 12 months of age, child will be able to play a simple ball game. Child will be able to play a simple ball game. At 15 months comes your 2 P's. At 15 months comes your 2 P's. What are these 2 P's? The first P is point towards object. Child will start to point towards object. The second P is point towards wet pants. So he'll point towards his own wet pants. Oh, I have wet my pants. Please change me. So point towards object and point towards his own wet pants. 2 P's at 15 months. 2 P's at 15 months. At 18 months comes 2 D's. At 18 months will come 2 D's. Okay, what are these 2 D's? The first D is domestic mimicry. The first D is domestic mimicry. It is what? Domestic mimicry. As far as domestic mimicry is concerned, what will happen in domestic mimicry? The child will mimic the task that the mother and the parents are doing. The mother is brooming, mother is cleaning the house with a broom. Child will also start to pick up a broom and imitate the parents. This is what is called as domestic mimicry. The second D is dry at day. The child will be dry at day. The child will be dry at day. Alright. Next comes at 2 years of age. Next comes at 2 years of age. At 2 years of age comes what will come? Parallel play will come. What will come? Parallel play will come. So if you have 2 children in a single room, they will play parallelly. They won't play with each other. They will play parallelly. One child will play with his own set of toys. The other child will play with his own set of toys. This is what is called as parallel play. At 3 years of age, child knows 3 things about himself. Child knows 3 things about himself. Child knows 3 things about himself. What are these 3 things? What are these 3 things that the child will know about himself? These 3 things are name, age, and gender. Name, age, and gender. Name, age, and gender. Name, age, and gender. Then at the same point of time, name, age, and gender is at 3 years of age. Okay, so 3 things about himself, name, age, and gender. And at this point of time, cooperative play will start. What will start? Cooperative play. So the 2 children who are playing parallelly with each other now will start to play with each other. And at 4 years of age, finally, role play will start. What will start? Role play will start, or group play will start. So they'll start to play in a group, or they start to role play. What is role play? 50 Shades of Grey? No, not, but kind of like that. So basically when children play Ghar Ghar, you are a police, I'll be the thief, catch me. That's exactly what example of a role play is. Alright. So role play, group play, that all will start at what? 4 years of age. It will start at 4 years of age. Now we come to the last, that is your language milestones. At 2 months, vocalization is going to start. At 2 months, vocalization is going to start. At 3 months, child starts to coo. Cooing will start. So coo has 3 letters in it. 3 months has 3 in it. So cooing will start at 3 months of age. 4 months, 4 has 4 in it. Ha ha. Ha ha also has 4 letters in it. So child will be able to laugh out loud. Child will be able to laugh out loud at 4 months of age. At 6 months of age, what will happen? Monosyllabic babbling. Monosyllabic babbling will start at 6 months of age. That is ma, ba, da. Ma, ba, da. At 9 months, this monosyllabic babbling will become what? It will become bisyllabic babbling. It will become what? Bisyllabic babbling. It will become bisyllabic babbling. It will become what? Bisyllabic babbling. Bisyllabic babbling. Alright. At 12 months of age, finally the child will be able to say one word with meaning. So 12 months is what? 12 months is 1 year. So 1 year, one word with meaning. 1 year, one word with meaning. 1 year, one word with meaning. At 15 months, 15 has 5 in it. So vocabulary will be 5 words. It's said to be between 4 to 6 words. 4 to 6 words. Alright. And at 15 months comes jargon speech. Comes what? Jargon speech. Comes what? Jargon speech. Okay. 18 months. 18 has what? 18 has 8 in it. So vocabulary will be what? 8 to 10 words. It will be what? 8 to 10 words. It will be what? 8 to 10 words. At the same point of time, child starts to do what is called as picture naming. Child starts to do what is called as picture naming. Child starts to do what is called as picture naming. At 2 years of age, child will be able to say 2-word sentences. Child will be able to say 2 years, 2-word sentences. 2 years, 2 words. What are these 2-word sentences? I go, you come, he goes. Alright, all these are example of 2-word sentences. And what are these? What is this you, I and he? These are examples of pronouns. These are example of pronouns. So child will be able to use pronouns also at 2 years of age. Child will be able to use pronouns also at 2 years of age. At 3 years of age, I've already told you, child is able to say name, age and gender. Child will be able to repeat 3 digits. Child will be able to repeat 3 digits. Child is able to repeat 3 digits. At 4 years of age, 4 has 4 letters in it. Past has 4 letters in it. Poem also has 4 letters in it. So child is able to use past tense and child is able to tell a poem or a story. Child is able to tell a poem or a story. At 5 years of age, past becomes what? Past becomes future. Child is able to use future tense. Child is able to use future tense. Child has child is able to use future tense and child asks meaning of words. Child asks meanings of words. Child asks meaning of words. Child asks meaning of words. Just give me a moment. Alright. Apart from this, another important milestone you should remember, that when does handedness gets developed? When does handedness gets developed? Handedness comes at 3 years. So child will become a righty or a lefty at 3 years of age. Child will be able to differentiate that this is right side or left side. Obviously it will come after handedness. So the right left differentiation, this actually comes at 4 years of age. So at 3 years he will become righty or a lefty, and at 4 years he will be able to say, okay, this is the right side, this is the left side. So right left differentiation comes at 4 years of age. And another thing, binocular vision, this comes at 4 months of age. Binocular vision comes at 4 months of age. Alright, so these are the important milestones, and I hope I made them at least, see, I'll be very, very honest with you guys. Milestones is something, no matter how much mnemonics you use, you will forget. And then they are important and they will be asked. So I'll ask you guys to revise them 1 day or 2 days prior to the exam. In fact, in the exam which I gave also, I revised it on the way to the exam. In the car when I was going to the center, I revised the milestones. And I was lucky that this very second question that was there in the exam was actually of milestone. I think the first or the second question in the exam itself was of milestone. And after that, I forgot the milestones till the time I started teaching pediatrics, obviously. Milestones are that volatile. Milestone, irrespective of how much you ever try, yes, you can remember the broad guidelines that might help you solve the question in many cases, yes. But having said that, despite all the revision, you should, I would say, revise the milestones 1 or 2 days prior to the exam. Alright, and it will definitely give you a boost because you will be able to answer that 1 or 2 questions that from milestones that will end up coming. Now let's discuss a little bit about the respiratory disorders as far as neonates are concerned. We have completed general pediatrics. Now a little bit about respiratory system neonates disorders. I'll go a little fast because already we are at 9:50. Already we are at 9:50. Alright. So let's start. First, as far as respiratory distress systems and disorders in neonates are concerned, first disorder that I'm going to discuss is respiratory distress syndrome or RDS. Now, why does this RDS occur? It typically is seen in less than 34-week preterms and typically seen because there is a deficiency of surfactant. There is a deficiency of what? There is a deficiency of surfactant. If surfactant is not there, lack of what is going to happen? Lack of increased surface tension is going to be there. Increased surface tension will result in collapse of alveoli. For this, we use something called as LS ratio. L stands for lecithin. L stands for lecithin. Lecithin is a main component of surfactant. It is a main component of surfactant. Obviously, if the surfactant deficiency is there, the L part of the LS ratio will go low. So overall, the LS ratio is going to be low. At any given point of time, LS ratio is less than 2. We'll say the risk of having RDS is high. The risk of having RDS or respiratory distress syndrome is high. What will X ratio? If there is proper alveolar collapse, what will happen? If all the alveoli are collapsed, what will happen? You will have a whiteout lung. You will have what? You will have whiteout lung. You will have whiteout lungs. And in those whiteout lungs, what will you see? In those whiteout lungs, what we will see? See the periphery, the alveoli, they are all collapsed. The alveoli, they are all collapsed. So they will appear what? They will appear properly white. They will be totally white. But the main bronchus, they will still have air. The bronchus will still have air. They won't be collapsed. The alveoli in the periphery are collapsed, but the bronchus in the middle, they are not collapsed. This will appear as air bronchograms. Alright. So the periphery will be complete whiteout, but in the middle you will be able to see the shadow of air in the thick bronchus which are still not collapsed, which is referred to as air bronchograms. Let's see the X-ray ones. So this is how the X-ray looks like. Complete whiteout. But despite the complete whiteout, can you see the shadow of air here? This is what is called as air bronchograms. These are air bronchograms. So there is complete whiteout in the periphery. But if you look closely here, again, here you can see a bronchus and here you can see a bronchus. This is what is called as air bronchogram. And this will be the X-ray of a child with respiratory distress syndrome. As far as treatment is concerned, you can prevent it using antenatal steroids. Which antenatal steroids? You can use betamethasone or you can use dexamethasone. The doses are important. For betamethasone, B for beta, B for 12. So doses 12 mg. We give 2 doses only, 24 hours apart. For dexa, the dose is 6 mg given 4 times. So the total dose is again 24, given 12 hours apart. So these antenatal steroids, they can help in prevention of RDS. Alright. As far as treatment is concerned, what is there? What is lacking? Surfactant is not there. So give surfactant, right? So as far as treatment is concerned, we can give surfactant. To these children. The method to give surfactant is either ensure. Ensure stands for intubate, surfactant, extubate. And there is another method called as LISA. LISA stands for less invasive surfactant administration. LISA stands for less invasive surfactant administration. Alright, so these are the two methods. You can use as far as treatment of RDS is concerned. Then we come to apnea of prematurity. Now, as far as apnea of prematurity is concerned, the name itself is telling you there is what? There is apnea because there is prematurity. The reason there is apnea of prematurity is because there is these babies have not matured, they are not become term, and their ANS system, their chemoreceptors in the brain are immature. And this immaturity does not allow them to breathe spontaneously, resulting in apnea. So why does apnea occur? Because there is a immaturity of their ANS and chemoreceptors. Because of their ANS, there is antenatal, their autonomic nervous system and chemoreceptors. Because they are immature, they are not able to sense that now we have to breathe. They keep on being in a prolonged apnea-like state. Apnea is said to have occurred if it is lasting for more than 20 seconds. If it is lasting for more than 20 seconds. What is the treatment? So they are essentially sleeping, right? Wake them up. What do we use when we want to wake up? Coffee. We use the same thing as far as children are also concerned, neonates are also concerned. We give them caffeine citrate. We give them what? Caffeine citrate. It is an adenosine blocker. It is what? It is an adenosine blocker. By giving this adenosine blocker, what we'll do? We'll wake them up. We'll improve the sensitivity of these chemoreceptors. We'll increase their sensitivity, so the apnea will automatically resolve. As far as X-ray is concerned, the X-ray is going to be normal. The X-ray will be normal. The X-ray is going to be normal. There's no problem in the chest, right? Only the immaturity in the CNS receptors was there. Next comes TTNB, which is transient tachypnea of newborn. Now, this transient tachypnea of newborn typically is seen in LSCS. It is typically seen in LSCS. Now, why is it seen in LSCS and not in normal delivery? Normally, when through a normal delivery, a child is getting born. If a child is getting born through a normal delivery, there's going to be a lot of sympathetic stimulation. It's a very violent process. This sympathetic stimulation results in absorption of lung fluid. This sympathetic stimulation is absolutely lacking during a LSCS. Because the sympathetic stimulation is lacking during LSCS, there is retention of lung fluid, and this retention of lung fluid in turn results in this transient tachypnea of newborn. So why does it occur? It occurs because of retention of lung fluid. It occurs because of retention of lung fluid due to lack of stimulation in a LSCS. Typically seen in LSCS, typically seen in infant or diabetic mother, typically seen in males. What is going to be treatment? Nothing, supportive. Over a period of time, this lung fluid will get absorbed. That's why it is called transient tachypnea of newborn. Because this lung fluid absorption is only delayed. It is not that it won't occur at all. So it will resolve on its own. So treatment is going to be just supportive. Treatment is going to be just supportive. What is X-ray going to show? X-ray is going to show a fluid. It's going to show fluid in the horizontal fissure. There is excess of fluid, right? Excess of lung fluid. This excess of lung fluid will be there in the horizontal fissure. There will be horizontal fissure fluid. There's going to be horizontal fissure fluid. There's going to be horizontal fissure fluid. So this is how it looks like. Can you make out horizontal fissure fluid here? Can you make out a little bit of fluid here? So this horizontal fissure fluid is what will be characteristic of your TTNB. Then we come to MAS. MAS is what? It is meconium aspiration syndrome. Now what will happen in meconium aspiration syndrome? We know meconium has what? Meconium is made up of bile salts. It's made up of bile salts. These bile salts are going to stimulate and cause chemical pneumonitis. They are going to cause chemical pneumonitis. These bile salts can completely obstruct an airway, causing complete collapse called as atelectasis. And if they are partially obstructing the airway, if there is partial obstruction, then what will happen? The air will keep on going inside, won't be able to come out. Air will keep on going inside, won't be able to come out, resulting in hyperinflation. So you will see all these three things together. You will see chemical pneumonitis, you will see chemical pneumonia-like picture, you will see collapse, and you will see hyperinflation. All these three things together will be seen as far as X-ray is concerned. Treatment, again, no particular treatment, it's only supportive. It's only supportive management. Wait, ensure child doesn't die, and child requires mechanical ventilation, give mechanical ventilation. That's about it. Supportive treatment. Alright. So this is how a chest X-ray of a child with meconium aspiration syndrome looks like. You can see a pneumonia-like picture. At the same point of time, can you appreciate 1, 2, 3, 4, 5, 6, 7, 8, 9, 10. Hyperinflation. There is hyperinflation. And can you appreciate how the opposite side lung is actually collapsed? The upper lobe is actually collapsed. So you have collapse, you have atelectasis, you have hyperinflation, and you have a pneumonia-like picture. All these three things together occurring is what is called as meconium aspiration syndrome. All these three things occurring together is what will be there in meconium aspiration syndrome. Last respiratory tract disorder is PAP. That is your pulmonary alveolar proteinosis. It is your pulmonary alveolar proteinosis. In pulmonary alveolar proteinosis, there is a functional surfactant deficiency. There is a functional surfactant deficiency. There is mutation in SPB protein. There is a mutation in SPB protein. It is inherited in autosomal recessive manner. Now, amount of surfactant is normal. Amount of surfactant is normal, but the surfactant which is there is non-functional. So this will actually present in term babies. It will present in term babies with respiratory distress syndrome like manifestation. It will present in term babies with respiratory distress syndrome like management. And because it is autosomal recessive in nature, most of the times they will give you a history of sibling death. Most of the time they will give you a history of sibling death. They will give you a history of sibling death. Alright, so in pulmonary alveolar proteinosis, there is going to be functional surfactant deficiency. It's autosomal recessive. Seen in term, okay, not in preterm. Preterm there was quantitative surfactant deficiency. Here it is going to be what? Here is going to be functional or qualitative surfactant deficiency. And there will be history of sibling death. Treatment is lung transplant. Treatment is lung transplant. Prior to lung transplant, you can also try lung lavage. Alright. Now, a little bit about how do you manage respiratory distress or how do you measure respiratory distress. These two scores are very, very important, frequently tested again and again and again. These two scores are your Silverman-Anderson score or SAS for short, and the second is your Downey score. Silverman-Anderson score is used in preterm babies. Downey score is used in term babies. Silverman-Anderson score correlates with mortality. It correlates with mortality, while Downey score correlates with morbidity. This is one thing that you should remember. Now, as far as the components of Silverman-Anderson score are concerned, these include your upper chest retractions, lower chest retractions, xiphoid retractions, nasal flaring, and grunting. These are the 5 components of Silverman-Anderson score. They are scored as 0, 1 and 2. As far as upper chest retraction is concerned, score 0 will be given when there is no upper chest retraction. Score 1 is given. Now listen to this very carefully. Imagine this is upper chest and imagine this is the abdomen. This is the upper chest and this is abdomen. If there is a chest pathology, if there is respiratory distress, what will happen? Whenever the child is trying to breathe, what will happen? The abdomen will go up. That's what normally happens. Yes, the abdomen will go up. But because there is a pathology in the chest rise is going to be small. So abdomen will go up, chest won't move up. It won't fully move up. There will be a lag. If there is a lag, we'll give it a score of 1. Now imagine the chest pathology so much that the abdomen has gone up, chest hasn't moved at all. Now the abdomen is coming down, chest is moving up. Chest come down, abdomen moves up. So can you call that this kind of movement where one portion is going up, other is coming down, other is going up, next is coming down? This is what is called as seesaw movements. Seesaw movements. And if there is seesaw movements, we give it a score of 2. As far as lower chest retractions are concerned, if none are seen, there is score of 1. It's a score of 0, sorry. If minimal chest retractions are seen, we'll give a score of 1. If marked chest retractions are seen, we'll give a score of 2. Same goes for xiphoid, no minimal marked, 0, 1 and 2. Again, same for nasal flaring, no nasal flaring, 0. Minimal nasal flaring, 1. Marked nasal flaring, 2. As far as grunt is concerned, grunt is a respiratory sound. If no grunt is heard, we'll give a score of 0. If grunt is audible with a stet, we'll give a score of 1. If it is audible without a stet also, it is audible with ear, we'll give a score of 2. So maximum score of 10 is possible. A minimum score of 0 is possible. Remember that. Then we come to the Downey score. Downey score has again 5 components. Like I said, Downey's is used for term babies. It has again 5 components. The 5 components of these Downey scores are retraction, air entry, respiratory rate, cyanosis, and grunting. These are the 5 components of Downey score. Alright, remember that. Again, if no retractions, 0. Minimal retractions, score of 1. Marked retractions, score of 2. If air entry is equal, score of 0. If air entry is bilaterally decreased, score of 1. If it is bilaterally absent, score of 2. Respiratory rate less than equal to 60 is 0. 60 to 81, more than 82. If there is no cyanosis, score of 0. If there is cyanosis on room air, score of 1. If there is cyanosis on more than 40% oxygen, then score of 2. Grunting again absent. Audible with stet, score of 1. And if it is audible without stet also, audible with the ear, if it is audible with the ear, then a score of 2. So this is how we score Downey. Remember, it is used for term babies. If the score is between 0 to 3, it is called as mild respiratory distress, which can be taken care with just giving a little bit of oxygen. If the score is between 4 to 6, it is moderate respiratory distress. We require CPAP. If the score is more than 7, it is severe respiratory distress, and you will require what? You will require mechanical ventilation. Alright. So this is as far as your respiratory distress in neonates is concerned. Most of the questions on neonatology will come from this only. Now we move on towards genetics. We'll discuss a little bit about Down syndrome, difference between Edward and Patau, and difference between Turner and Noonan. Quickly, within the next 5-10 minutes, we'll discuss the differences between them. As far as Down syndrome is concerned, I won't discuss the actual features. You all know the features. Most of the questions actually come from prenatal detection. Alright. Now we all know Down syndrome is what? It is trisomy 21. 95% cases occur because of non-disjunction of maternal chromosome. During meiosis. During what? During meiosis. Alright. As far as prenatal detection is concerned, in first trimester, as far as serum markers are concerned, you can use 2 markers, beta HCG and PAPA. Beta HCG is usually higher than normal. This PAPA, pregnancy associated plasma protein A, this is low. These 2 things together are called as dual test. This is what is called as dual test. In second trimester, you can use beta HCG, alpha fetoprotein, and unconjugated estriol. UE3 stands for unconjugated estriol. Beta HCG again is going to be high. Alpha fetoprotein is usually low. UE3 is usually low. These 3 things together are called as the triple test. It's called as triple test as far as second trimester is concerned. If we add to this triple test use of inhibin A, then it will be called as 4 things are now there, so it will be called as quadruple test. Inhibin A is usually increased. How do you remember this? Simple mnemonic: high. High is high. So HCG, beta HCG and inhibin, they are high. Rest everything is low. Alpha fetoprotein is low, PAPA is low, UE3 is low. So HCG, beta HCG and inhibin, these are the 2 things only which are high. Rest everything is low. As far as ultrasound markers are concerned, this includes your absent nasal bone and increased nuchal thickness and translucency. So these are the ultrasound or the radiographic parameters. If you use the radiographic parameters along with the dual test, these 2 tests combined together will be called as combined test. If the combined test, if this combined test is used with the triple or the quadruple test, if the combined test is used with the triple test or the quadruple test, it is called as integrated test. It is called as integrated. So combined test is done in first trimester, integrated test is done in second trimester. Alright, so this is another important difference. Most of the questions will come from this prenatal testing. Just remember, high is high. High means HCG and inhibin A. These are the only two things which are high as far as Down syndrome is concerned. Rest everything is low. Rest everything is low. Okay. Then we come to the difference between Edward and Patau syndrome. For the differences between Edward and Patau syndrome, the only thing that you need to remember, is the sound of P. If the sound of P is there, it is going to be in Patau. If the sound of P is not there, it is going to be in Edward. Always remember the sound of P or P. P for Patau, P for everything that is there in Patau syndrome. Just remember this, everything will become easy. Alright, let's see how that happens. So we know Edward syndrome is Edward, E for 18. Edward is trisomy 18. Patau, P for Patau, P for puberty. Puberty occurs at 13 years. Patau is trisomy 13. Okay. Let's see. Cleft palate. P sound is there. So cleft palate will be there in Patau. It won't be there in Edward. Fingers. Polydactyly. Polydactyly will be seen in Patau, while Edward has overlapping fingers. Edward has overlapping fingers. Rocker bottom feet. No P sound. Rocker bottom feet. There is no P sound. So no P sound, not in Patau. Rocker bottom feet will be seen in Edward. It won't be seen in Patau. As far as kidneys are concerned, polycystic kidneys. P for polycystic, P for Patau. So Patau will have polycystic kidneys, while Edward will have horseshoe kidney. Horseshoe doesn't have P sound. Edward will have horseshoe. Kidney, no P sound. P sound, polycystic, Patau. Holoprosencephaly. Again a P sound, holoprosencephaly. So holoprosencephaly will be seen in Patau, it won't be seen in Edward. So this is a simple way you can differentiate between Edward and Patau syndrome. Alright, let's look at the images. This is cleft lip and cleft palate. So this will be Patau. This will be what? This will be Patau. Alright, look at this. This is 1, 2, 3, 4, 5. This is not polydactyly. This is overlapping fingers. So this will be Edward. And look at this image. These are the rocker bottom feet. Again, rocker bottom feet. No P sound. No P sound means Edward. Means what? This again will be a picture of Edward syndrome. Moving on towards the differences between Turner and Noonan. What is the difference between Turner and Noonan? So you have to understand that Turner and Noonan both have same phenotype. That is, if you look at them physically, phenotypically, they will be exactly same. So Turner and Noonan have the exact same phenotype. And what is this phenotype? I like to call this phenotype as 3 Ws. I like to call it as 3 Ws plus short stature. What are these 3 Ws? You can see the widely spaced nipples, the webbed neck, the widely spaced nipples, the webbed neck, and wide carrying angle. Wide carrying angle is cubitus valgus. Wide carrying angle. These are the 3 Ws plus short stature. This is the phenotype. This is going to be the physical appearance. This physical appearance is exactly the same. It's exactly the same between, that is the 3 W's plus short stature. The 3 W's plus short stature would exactly be the same between Turner and Noonan. The difference is, why is it occurring? Noonan is a sex aneuploidy. We all know Noonan is what? Noonan is XO. It is a sex aneuploidy, right? While, sorry, Turner is a sex aneuploidy. I'm so sorry. In the flow I said Noonan. Turner is a sex aneuploidy. It will be XO. Turner is a sex aneuploidy. It will be XO. While Noonan is a autosomal dominant disorder. Noonan is a autosomal dominant disorder occurring because of mutations in PTPN11. Occurring because of mutation in PTPN11. Now Turner is what? XO. So Turner will only be seen, there is only one X chromosome. Turner will only be seen as far as girls are concerned. They will always be girls. While Noonan is autosomal. Noonan is what? Noonan is autosomal. Since it's autosomal, Noonan can be seen in both males and females. Noonan can be seen in both males and females. Another important difference between Turner and Noonan is, in Turner syndrome, as far as heart is concerned, you have bicuspid aortic valve. Or you can have coarctation of aorta. You can have coarctation. Basically, it defects on the left side of the heart. While in Noonan syndrome, you have defects on the right side of the heart. You have what? You have pulmonary stenosis. Moving towards the IQ. In Turner, IQ is normal. Very important to understand. In Turner, IQ is normal. These girls are not retarded. Perfectly normal. While in Noonan, IQ is low. And last, fertility. Turner is sex aneuploidy. So they will be having streak ovaries and they will be infertile. While in case of Noonan, fertility will be present. Menses also will be present in case of girls. Fertility will be present, menses will be present. They do have subfertility, but overall they are not infertile. While in case of Turner, always infertile. So this is the difference between Turner and Noonan syndrome. A little bit about congenital infections. Just the important triads. I'll just enumerate the important triads. Toxoplasma has chorioretinitis, calcifications, and hydrocephalus. Congenital rubella syndrome triad, very important, frequently tested. Cataract, patent ductus arteriosus, and sensory neural hearing loss. Particularly this PDA is a very frequently tested fact. Then comes CMV, congenital CMV. Remember, 90% of congenital CMV infections are asymptomatic. They are actually asymptomatic. But even these 90% cases which are asymptomatic, later in life, they can end up having sensory neural hearing loss. In fact, it is the most common cause of non-syndromic SNHL. Very frequently tested fact as far as INICET is concerned. Keep on asking again and again. The best method to detect it in first 3 weeks is urine CMV PCR, and the treatment is Ganji cyclovir. The triad of CMV can be remembered by the mnemonic CMV itself. What is the triad of CMV as far as congenital CMV is concerned? It is chorioretinitis, microcephaly, and periventricular calcification. This is a triad of CMV. With this, we complete congenital. Remember, this CMV is the most important infection. If you have to remember one infection before going for the exam, before you are going to go for the exam, always ensure that you remember CMV. CMV is the only one which is CME is the only one which they frequently keep on asking as far as your INICET is concerned. As far as your INICET is concerned. All right. Okay. All right. Let me move on. I'll respond to easy okay life after a point of time. Now let's discuss the last thing. Now we'll move towards systemic pediatrics. I'll discuss about the management of diarrhea. I'll discuss cystic fibrosis and then we'll take leave. I'll discuss cystic fibrosis. I'll discuss the management of diarrhea and then we'll take leave. That is the only important thing as far as your we have covered most of the important topics of the pediatrics in this 2.5 hour session. As far as diarrhea is concerned in children, the most common cause is rotavirus. It is rotavirus. Most common bacterial cause is E. coli. Remember that Giardia does not cause acute diarrhea. Remember that Giardia, it's a line given in Ghai that Giardia never causes acute diarrhea. And rice watery stools are seen in cholera. Rice watery stools are seen in cholera. Alright. Rice watery stools are alright. Alright. So I would as far as the PDF is concerned, afterwards I will send the PDF towards in the DBMCI group. Don't worry about that. I'll send the PDF in the DBMCI group. Let's just complete this topic. Let's complete diarrhea and cystic fibrosis. These are the two most important topics on systemic pediatrics. Like I said, the focus of the session of these 2.5 hours was general pediatrics, so that most of the important topics of general pediatrics are at least covered. Systemic pediatrics, I'm pretty sure a lot of it will already be covered in medicine, pathology, pharmacology, biochemistry, and a lot of it will already be covered in other subjects. So that's why I ensure that at least general pediatrics is covered a little more in depth, while systemic pediatrics you can cover for yourself as far as revision part is concerned. Now, as far as management of diarrhea is concerned, always remember that management of diarrhea is related only to management of dehydration. A child doesn't die from diarrhea. Child dies from dehydration. Now, how do you assess for dehydration? As far as assessment of dehydration is concerned, after we do assessment of this dehydration clinically, we do it clinically. A child will come to us and will clinically assess that the child is suffering from, and will classify whether the child is suffering from no dehydration, some dehydration, or severe dehydration. Our child will come to us, will clinically assess the child for the status of the dehydration, so status of hydration status of the body, whether the child is suffering from no dehydration, some dehydration, or severe dehydration. And how do we do that clinically? Let's discuss that. We basically are going to use, four parameters. We are going to use how many parameters? 4 parameters. Consciousness, skin pinch, eyes, and thirst. Consciousness, skin pinch, eyes, and thirst. In no dehydration, child is fine. There is no dehydration, right? So child will be active. In some dehydration, because obviously now some fluid loss has already occurred, child will be what? Child will be very, very irritable because the fluid loss has occurred. So child will be what? Irritable. And in severe dehydration, what will happen? Because now the body has lost so much water, child will be lethargic. Child will be what? Child will be lethargic. Alright. Now, as far as thirst is concerned, I'll consider thirst first because it's directly related to consciousness. In no dehydration, thirst will be normal. Thirst will be what? Thirst will be normal. In some dehydration, child has lost some water. Child is irritable. Why is child irritable? Because he wants that water. He's not getting water. He's dehydrated. That's why he wants that water. So child will be very thirsty. He'll be eager to drink water. So drinks eagerly. Or child is very thirsty. Child is very, very thirsty. In severe dehydration, now child has lost so much water. Child is lethargic, comatose. Do you think the child will be able to drink water? Do you think a comatose child will be able to drink water? No, right? So child won't be able to drink water. So as far as thirst is concerned in severe dehydration, child is unable to drink water. As far as skin pinch is concerned, skin pinch will be normal in no dehydration. Skin pinch will be delayed in some dehydration. Skin pinch will be very delayed in severe dehydration. As far as eyes are concerned, eyes will be normal in no dehydration. Eyes will be sunken in some dehydration. They will be very sunken They'll be very sunken in severe dehydration. They'll be very sunken in severe dehydration. So how do you classify? How do you classify? If there is any 2 out of the 4, and you will take the higher classification. You will take the higher category, or you will take the higher classification if there is any 2 out of the 4. I'll explain it with the help of an example. Let's say the child is lethargic, skin pinch is very delayed, eyes are sunken, and child is drinking water eagerly. Let's say this is the clinical scenario given. So 2 out of the 4. 2 out of the 4 of severe is being met. So higher one is going to be chosen. 2 out of the 4 of some is also going met. Some dehydration is also met. But we'll choose the higher category. So 2 out of 4 and the higher category. Any 2 out of the 4 is being met, you will choose the higher category and classify the child as having no, some or severe dehydration. Alright. So with these 4 parameters, you will first classify the child as having no, some and severe dehydration, 2 out of 4. Whichever is higher, choose that. Whichever is higher, choose that. Okay. In case of no dehydration, the approximate fluid loss is said to be less than 50 ml per kg. In some dehydration, the approximate fluid loss is between 50 to 100 ml per kg. And in severe dehydration, it is from approximately 100 ml, more than 100 ml per kg. Now coming to the management. Management involves 3 plans. Plan A, Plan B and Plan C. Plan A is used for no dehydration. Plan A is used for no dehydration. In no dehydration, there is no dehydration. The name itself is telling you there is no dehydration. So what will you do? You'll just give ORS to replace ongoing fluid losses. Child can continue to have loose stools. So just ensure whenever he's having a loose stool, you give him ORS. That's it. So you are going to do what? You are just going to replace ongoing fluid loss. You're just going to replace ongoing fluid loss with ORS. You're going to give 10 ml per kg of ORS with each loose stool. So every time your child has loose stool, just give him 10 ml per kg of ORS. So 10 kg child, 100 ml ORS. Every time child has a loose stool, give him 100 ml of ORS. That's it. Since there was no dehydration, you don't need to rehydrate. Every time child has a loose stool, just replace the ongoing fluid loss. As far as this ORS is concerned, this ORS is made up of sodium, potassium, glucose, chloride and citrate. It is sodium, potassium, glucose, chloride and citrate. Now sodium is given is 75 millimole per liter. It is what? 75 millimole per liter. Potassium is 20 millimole per liter. Glucose is also 75 millimoles per liter. Chloride is 65 millimole per liter. And citrate is 10 millimole per liter. Citrate is what? 10 millimole per liter. So that the total osmolality of this ORS is 245. This is considered the low osmolality solution of ORS. Earlier ORS used to be 310. Earlier it used to be 310, 311, which was considered the standard osmolality. Now we use this 245 osmolality ORS called the low osmolality ORS. There is a reason the sodium and glucose are 75-75. They are 1:1. They are 1:1. Why? They are 1:1 because they stimulate the SGLT1 receptor. They stimulate the SGLT1 receptor for absorption of sodium. So plan A is simple. Just give ORS 10 ml per kg with each loose stool. That's it. Moving on towards plan B. Plan B, what is there? There is some dehydration. And we said that in some dehydration, the fluid loss is between 50 to 100 ml per kg. So you have to replace that fluid. You have to rehydrate the child. So what fluid are we going to use? We are again going to use ORS only. We are going to rehydrate with ORS only. This ORS can be given orally or via NG. If the child is not taking orally, we can give it NG. How much? So between 50 to 100 ml per kg, the middle point, 75 ml per kg. So we do what? We give 75 ml per kg of ORS. We give 75 ml per kg of ORS over 4 hours. Over 4 hours. This is some dehydration. So in some dehydration, child had lot some water. You are rehydrating how much? 75 ml per kg. The middle point between 50 to 100. You are giving 75 ml per kg over 4 hours. You are giving ORS. Now we come to plan C. Plan C is used for severe dehydration. It is used for what? It is used for severe dehydration. It is used for severe dehydration. Alright. It is used for severe dehydration. The purpose of giving glucose and sodium in equal amounts is because of increased SGLT, or in some Q bank is given as correct acidosis. No, it's the same. It is to give it in 1:1 ratio. The reason we are giving it in 1:1 ratio is to stimulate SGLT1. I'm definitely sure about that. The reason it is given in 1:1 ratio is to stimulate in 1:1 ratio. It is for stimulating in 1:1 ratio. All right. So if question is asked about the fluids given, should we consider ORS also or just calculate the IV fluids? Remember, in plan B, we are giving ORS only. In plan B, we are not giving IV fluids. See, in plan B, what we are giving? We are giving oral NG. There is no role of IV fluids in plan B. There is no role of IV fluids in plan B. So we're going to calculate only ORS only. So 75 ml per kg of ORS over 4 hours. In plan B, you have to give how much? 75 ml per kg of ORS over 4 hours. No role of IV fluids. There is no role of IV fluids. Moving on to plan C. Plan C is used for what? Plan C is used for severe dehydration. 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 Alright, yeah. Plan C is used for severe dehydration. As far as severe dehydration is concerned, always remember, in severe dehydration, what has happened to the child? Child is lethargic, unable to drink. If the child is lethargic and unable to drink, do you think the child will be able to gulp down water, or can you give it orally? No, right? So in severe dehydration in plan C, you have to give IV fluid. You have to give what? You have to give IV fluids. Which IV fluids? Ringer lactate with 5% dextrose. RL with 5% dextrose. This is the preferred solution. If this RL with 5% dextrose is not available, consider RL. If RL is not available, consider NS. Consider NS. How much? So we said that in severe dehydration, the amount of fluid loss is what? It is approximately 100 ml per kg. So give 100 ml per kg. Give what? Give 100 ml per kg. This 100 ml per kg is given over 2 aliquots. It's given as 30 ml per kg and it's given as 70 ml per kg together. If the child is more than 1 year of age, the first 30 ml per kg is given over half hour. The remaining 70 ml per kg is given over 2.5 hours. The remaining 70 ml per kg is given over 2.5 hours. So that the total 100 ml per kg, is given over 3 hours. It's given over 3 hours. Alright. If the child is less than 1 year, then we have to give it little slowly. Child is smaller, right? So we have to give it little slowly. The first 30 ml per kg is given over 1 hour. The remaining 70 ml per kg is given over 5 hours. So that the total 100 ml per kg is given over 6 hours. Total 100 ml per kg is given over 6 hours. This is the management of severe dehydration, plan C, 100 ml per kg. Okay, that's it. Summarizing, let's summarize it. In plan A, what we are doing, we are giving ORS. We are giving it orally. How much? We are giving 10 ml per kg with each loose stool. In plan B, what we are doing, again we are giving ORS only. This time we are giving it NG or orally. How much? 75 ml per kg over 4 hours. 75 ml per kg over 4 hours. In plan C, now we are finally doing what? We are using RL with 5% dextrose. We are giving IV fluids. And we are giving how much? We are giving 100 ml per kg. Either over 3 hours or over 6 hours. Less than 1 year, over 6 hours. More than 1 year, 3 hours. Less than 1 year, 6 hours. More than 1 year, 3 hours. Alright. So this is a table which summarizes the management of dehydration. That's it. Now why do people get confused? People get confused because they get confused with this. They tend to get confused with this daily maintenance fluid. They tend to get confused with this daily maintenance fluid. Remember, daily maintenance fluid is independent of dehydration. It is independent of dehydration. What is this daily maintenance fluid? Daily maintenance fluid is nothing but the amount of fluid required to maintain you. It is the amount of fluid that we required on a daily basis. It has no relation whatsoever to dehydration. Don't confuse between two. Daily maintenance fluid is independent. This is the fluid that a child requires on a daily basis. This is the fluid that I require or you require on a daily basis. This is ekdam independent of dehydration. So don't confuse between two. These two calculations are done separately. If they ask you the preferred maintenance fluid, then the answer is going to be DNS. DNS is NS with 5% dextrose. Then the answer is going to be DNS. The preferred maintenance fluid is DNS. Alright. Now how do we calculate this maintenance fluid? If the weight of the child is between 1 to 10 kg, for this first 10 kg, it is calculated as 100 ml per kg. Okay. From 10 to 20 kg, it is calculated as, for each kg, we calculate it as 50 ml per kg. And beyond 20 kg, for each kg, per kg, we calculate it as 20 ml per kg. I'll give an example. Let's say there is a 14-year-old child. 14 kg child. Let's say there is a 14 kg child. So 14 kg child, first 10 kgs is 100 ml per kg. So 100 into 10 is equal to 1000. So 1000 ml. And then the remaining 4 kg. For the next 4 kg, we have to use 50 ml per kg. So 4 into 50 is equal to 200. So the total daily maintenance fluid will be 1200 ml in 24 hours. 1200 ml in 24 hours. So that's how you calculate the daily maintenance fluid. Alright. For the first 10 kg, 100 ml per kg. For the next 10 kg, 50 ml per kg. And for above 20, use 20 ml per kg. Again, example. Let's say there is a 21 kg child. So for the first 10 kg, 10 into 100 is equal to 1000. Right? Next 10 kg, 10 into what? 50. So 10 into 50 is equal to 500. And then only 1 kg is left. So 1 kg, 1 into 20 is equal to 20. So for this particular child, the daily maintenance fluid will come out as 1520. For a 21 kg child, it will come out to 1520 in 24 hours. Alright. With this, we complete the management of dehydration. Now let's discuss the semi-last topic, that is cystic fibrosis. After this, we'll just discuss the X-rays and CHTs and we'll take a leave. Remember, cystic fibrosis is inherited in a autosomal recessive manner. There is a mutation in a gene called CFTR gene, which is present on chromosome 7. This CFTR gene, the most common mutation is delta F508. It is what? Delta F508. This delta stands for deletion, F stands for phenylalanine, 508th is the 508th amino acid position. So at the 508th amino acid position, the phenylalanine which was there, it got deleted. This is the most common mutation. Okay, now this CFTR functions as a chloride conductance channel. How does it function? It functions as a chloride conductance channel. So what will happen? Let's see the pathogenesis. Now, the function of the CFTR in airway and pancreas is similar. Let's see what happens. Like I said, it's a chloride conductance channel. What it does, this CFTR gene will move the chloride. It will move the chloride from inside the cell into the lumen. Alright, it will move the chloride from inside the cell into the lumen. If chloride comes into the lumen, what will happen? Lover of chloride, the sodium will follow. So sodium also will come into lumen. Alright. Sodium also will come into lumen. Now if sodium chloride have come into lumen, what will happen? What will follow? Water will follow. Obviously, water will follow. If water comes into lumen, what will happen to secretions? Water will comes into lumen, the secretions will become watery. They will become very watery. The secretions become watery. This is the normal function of CFTR. CFTR ensures that the secretions are watery. What will happen in cystic fibrosis? Nothing of this sort will happen. What will happen in cystic fibrosis? This won't take place. This won't take place. And obviously this won't take place. So no water will come into lumen. So secretions won't be watery. Secretions will become very, very thick. And these thick secretions are the cause of everything as far as cystic fibrosis is concerned. If there are thick secretions in the lung, what will happen? You will have recurrent infections. Recurrent infections will lead to bronchiectasis. If you have thick secretions in pancreas, the enzymes won't be able to come out. You will have pancreatic insufficiency, pancreatic enzyme deficiency, pancreatitis. Later, you can have diabetes also. If you have thick secretions in intestine, there will be what? Constipation. There will be delayed meconium passage. There will be obstruction, distal intestinal obstruction, and rectal prolapse will also occur. And on top of that, God also gives them one more obstruction. It gives an obstruction at the level of vas deferens. God takes away vas deferens from them. They end up having congenital absence of vas deferens. The only place where the function of the CFTR is different is sweat glands. It is where it is different in sweat glands. In sweat gland, the CFTR helps in absorption of chloride. And simultaneously, it will help in absorption of sodium also. So in cystic fibrosis, when the CFTR is not functioning, what will happen? Chloride in the sweat gland lumen, will increase. Chloride in sweat lumen will actually increase. And this is used for diagnosis. This is used as a diagnostic tool. Okay. So what will be the clinical features? We already discussed. In lungs, you will have thick secretions, repeated infection leading to bronchiectasis. Most common organism is Staph aureus. Staph aureus is the most common organism. This is the most specific organism. In pancreas, the enzymes won't get secreted out. They will get activated within the pancreas itself, leading to pancreatitis. The enzymes will come into the intestine, will lead to what? Exocrine pancreatic insufficiency. It will lead to exocrine pancreatic insufficiency. This will lead to fat malabsorption. Called steatorrhea. In the gut, again, thick secretions won't be able to pass. Delayed meconium passage, distal intestinal obstruction syndrome, and continuous extra intra-abdominal pressure will result in rectal prolapse. And like I said, one extra obstruction is provided by God itself. There will be congenital absence of vas deferens in males, leading to infertility. As far as diagnostic criteria is concerned, whom will you test? People who have clinical features, or who have positive screening, or who have family history. 3 set of diagnostic criteria. I already told you sweat chloride will be increased. So if the sweat chloride is more than 60 milliequivalent per liter on 2 or more occasions, that is a diagnostic criteria. Or you can test for the mutation. 2 or more mutations in the CFTR gene. This CFTR is a chloride conductance channel. If chloride conductance is not there, potential difference problems will occur. So you can test for that abnormal nasal potential difference. There can be abnormal nasal potential. If any one of this is there, any one of the following is there, you will say what? There is cystic fibrosis. The last thing I will discuss is the treatment of cystic fibrosis. It is chest physiotherapy, ensure that the secretions come out, pancreatic enzyme replacement, and you can use newer drugs like ivacaftor and lumecaftor. These are newer drugs used for cystic fibrosis. Now, last thing is cyanotic congenital heart disease. This is a boot-shaped heart seen in tetralogy of Fallot. What are the 4 components of tetralogy of Fallot? There is pulmonary stenosis. This pulmonary stenosis will result in the right ventricle won't be able to pump blood into the pulmonary artery. It will result in right ventricular hypertrophy. If the blood is not getting into the pulmonary artery, where it will go? From the right ventricle, it will go to the left ventricle via a VSD. So the third component is a VSD. And the fourth component is overriding of aorta. So these are 4 components of tetralogy of Fallot. Next, this is egg-on string appearance. This is seen where? This is seen in transposition of great arteries. Alright, where the aorta comes from right ventricle and the pulmonary artery comes from left ventricle. This is what is called as transposition of great arteries. Then we have a box-shaped heart. We have box-shaped heart. This is seen in Epstein anomaly. Remember, Epstein anomaly will occur if you're taking lithium. And in Epstein anomaly, there is what? There is increased RA size, increased right atrium size. So normal heart is like this. Here the right atrium size has increased, resulting in the box-shaped heart. Last, you have the Snowman appearance. This is seen in TAPVC, total anomalous pulmonary venous connection. Total anomalous pulmonary venous connection. Alright. This will be seen in total anomalous pulmonary venous connection. So with this, we complete the revision. Most of the important topics I will at least covered through in this 2.5 hour marathon. I'm sorry if I was a little fast, but that is the entire purpose of revision. These videos are not meant for concept clearing. The time of concept clearing is 4-5 months prior to exam. Right now it is to ensure that, like I always say, why do I always keep on emphasizing on the last 10-day revision? I always keep on emphasizing on the last 10-day revision is because human memory is fragile. You might believe that, okay, this person is an intelligent person, or you might believe that this person is not an intelligent person. It doesn't work like that. Every single one of us who are MBBS doctors, we have a basal level of intelligence. We are above IQ. We are above average individuals. But no matter how intelligent we are, until unless we're like super genius, which none of us is, frankly, our memory is going to fail. And if our memory fails in the exam, you will get confused between two options. And it's better that you actually revise in the last 10 days so that you don't get confused between those two options. If you have gone through the entire material in the last 7 to 10 days, on the exam day, you will be able to get to those, you will be able to differentiate between those two options which are going to be confused. If you have not revised, those two options will be your bane. You will mark the wrong answer. And instead of getting a top 1000 rank, the rank will become 10,000 or 20,000. That's why that's the emphasis on the last 10-day revision. It 10x's or 100x's your actual potential. Every one of us has a basal potential of a 10 to 20,000 rank. You do a proper 10-day revision, you get to 1,000, you do a much better 10-day revision, you get to a top 100 rank. You don't do that revision, you fall back. That is why we are having these revision sessions, so that at least in a short period, 2 hours span of time, the most important topics are going right in front of your eyes and you don't make a mistake. Alright, I hope you enjoyed the session. This was a little longer than the most of the other sessions. It went almost till 3 hours, but hopefully I've covered most of the important topics of pediatrics. 2 topics I would say you have to do yourself, especially as far as INICET is concerned. That is your neonatal resuscitation. Second is your seizures and febrile seizures. They have been asking about this frequently in the recent exams. So ensure that you do these topics on your own. These topics would have taken much more time, so I did not touch upon these, but do these topics on your own. But rest of the most mota part of pediatrics is already done in this 2.5 hours. I hope you enjoyed this session. I'll take leave now. It's already been a little long. Thank you and have a nice day. And have a nice night. Alright. And this PDF will be available in the official DBMCI group. Do check out the link. The PDF will be available. So you can easily revise, go through this towards the last 7-10 days. Perfectly fine. Alright. Thank you and have a nice day. Sure. Bye.